I can explain how it will be after. And then the discussion which you will have learn after all the presentation. Okay? Take the question. Yes. I think that very quick. One line. Yes. We are already.
Voilà.
So I am supposed to welcome you in Annecy, which is more or less done from yesterday night, where I had the pleasure to welcome you at Les Pensières after such a long time where we could not see each other. During the COVID time, we try at the Foundation to reinforce the Foundation in many aspects. You have a new meeting room, with a lot of complex logistic behind me. We are today at the Fondation 170 people working at the Fondation, about 40% in France and the remaining 60% abroad in the different countries we are involved. We have been reinforcing our staff, our scientific direction avec Marc, qu'on a beaucoup renforcé, avec un new scientific advisory board who is shared by one of our board members in order to connect the scientific board with the life of the, and Marie-Paul Kini is chairing the SAB. And we have, due to gift from the shareholders of Biomérieux, able to reinforce particularly your labs during the COVID to be facing the COVID. We have also been able, and it's one thing, we have been able to adapt very quickly to the situation. That's the reason we discussed when Professor Muwambe called me about Ebola in Goma. We were able to produce very quickly a P3 laboratory in container and send him by Antonov to Goma through Kigali in Rwanda. We've been able also in Madagascar, when your president of Madagascar asked us to do something for the starving population in south of the island. We've been able to build with the French company Nutriset. We've been able to set up a also container factory we sent by ship to Fort Dauphin, and which is now in operation. Last week, we had the pleasure of being in Tunisia, where to open the new P3 laboratory inside the Institut Pasteur with our friend Professor Louchnier. So we keep moving, and we try to be active as much as we can. After 20 years, because when my father passed away, it was about 20 years ago, I had to run the Fondation, and we did it with the vision of Christophe, who was a MD, who has been intern in infectious disease and working a lot in Asia. And we've been able to set up the idea of sending abroad what we were able to control inside Lyon, which was diagnostic laboratory for infectious disease. And we started in 2004 by Cambodia, where we set up the Faculty of Pharmacy and with a lab inside for infectious disease. And in 2005, in Bamako, we established a big laboratory, Rodolphe Mérieux, and we discussing at lunch about the happy time of Mali at this time in 2005. At the end of next year, we will have 17 Rodolphe laboratories in the world. We will open, we were in Casablanca, we set up a P3 laboratory at Pasteur Institute in Morocco. We have, due to, she had the Christophe Price as Mrs. Quadri, and we gave to Francine Touni, we built a lab also, Christophe Laboratory in Brazzaville, which is now will be part of the network. We are moving to set up a laboratory, we had lunch for that, in Burkina Faso, which is a country where we used to go. And we set up also a laboratory in Mosul, in Iraq, which is not the easy place to be present. At the same time, we were building what was the vision of Christophe. I am also to build, I have no choice, the vision of my wife, otherwise I will be in trouble, which has to be, every time we move in a laboratory, we take a program for mother-child. And it has been very impressive to see what we have been able to achieve. We were in Lebanon in June, and we were able to open the house in Juris, in the Bekaa, near Baalbek. And I'm supposed to open the second maternity, which has the name of my colleague, who was Malian colleague, Youssouf Issabre, in Bamako. We were in Tunis, and we support a foundation run by women only. So it was for short time accepted, with the Baiti taking care of the women around the world which arrived to Tunisia in a very bad situation, which I say worse situation. So all the laboratory, I say, we've been able to do it with only the local scientists. We never had French people running a laboratory. I don't like French people outside of France. They would remain in France, it'd be sometimes much better. So we've been able to do it with the scientists locally. Was the example of Ogo Baradumbo, which has been for us, he has a room dedicated to his memory. And Ogo learned a lot about what we are supposed to do. And it's very important to listen and to go. I remember when the first maternity we set in Bamako, he took me and we had a long time to discuss with, at the time, the old people, now I don't say that anymore, but about the fact of speaking and spending 2 hours discussing after everything was easy to do. Sometimes we learn a lot. It's better to discuss after taking a decision, before taking a decision, after the decision is accepted. So today, what can I say at my old age and my long experience around the world? I always say that there is, in human being, a battle between what we say the Italian writer Gramsci said, battle between the pessimism of intelligence and the optimism of willingness. That's a big fight. Today, if I am intelligent, I can be only pessimist. It's true that when we look at the world, the Chinese-US conflict, I built the P4 in China, in Wuhan, for the French government. Now I am under the table because I don't speak anymore about that. When you look what's going on in South America, we're discussing at lunch with Brazil, Venezuela, Argentina. What's going on in Asia with Myanmar, where we are supposed to build a laboratory and we are stopped because of the civil war. The war situation being in Middle East, the situation is awful. In Africa, a lot of destabilization. And I have a special thinking for my friends of Haiti, mon cher Bill, and the friends of Lebanon, ma chère Marianne. There are countries, which are suffering and a lot, and we try to help you. The world today, for me, is run by complexity, by discontinuity, and unfortunately by violence. Violence due to malgovernance, to corruption, and poverty. So it's a big fight. So you can be pessimist and close the door and drink red wine for French people, but I don't think it beats the solution. I think the solution is to keep the optimism of willingness. And really, this meeting from yesterday gave me a good booster of optimism, because you are all together, you work intensively, you don't care about the border of your country, we don't care about the religion of your country, we don't run about the political situation of your country. We work, and I think, it would be strange to say that, but I think that this COVID can be useful for all of us. It can be useful because first we are learning a lot. We learned modesty, we learn to be humble, and we also work with a lot of ambition. The experience we have with COVID, first we've been able to develop rapid testing in all matter in serology and antigen, but at the meantime, people like my old colleague, Stéphane Bancel, have been able to develop Moderna and in 1 year to produce a vaccine. So it's something which is fantastic. Science can be faster and very efficient. So I think today, if I am optimistic, I say the virus does not know any border, does not take care if it's a dog or human beings, does not take care if you are rich or poor. They make people equal around the world. And I think that COVID is not the last one of the series. The way I travel in the world, the way I see deforestation, climate change, crazy governance, poor, non-intelligent people running the country, corrupted people. I think the virus will learn us to be more intelligent and more working together. So I am really optimistic because what we do is much more important than the politicians do. In fact, we are much better, much stronger, and more useful than poor politicians. You know, I was in Tunisia, as I said last week. My friend Ekmelou Louznir is a specialist in leishmanios and rabies. I've been able to call Stéphane Bancel in Moderna, and they send the troops, you know, and they start working at the concept of vaccine, first for dogs, leishmania and rabies, and after human. You know, in Maghreb, people in Tunisia don't speak to Algerian, and Algerian and Morocco, they fight. But they all face leishmania and rabies. So I think when you will be able to develop vaccine, able to take care of those two diseases, which are really terrible in the country with errant dogs, I think we'll achieve much more than politicians. So I decided to be, at my age, I have no choice, to be really fantastically optimistic. Because what we do, what we have in hands is fantastic if we are able to handle it with care and with a vision of the world, which is, I think, more open than sometimes. So it's really my pleasure to have spent a day with you. I think that, speaking about Bill, in Haiti, Bill is fantastic, but also Frère Armand and Sir Armel are people who are fighting for orphan people, but in a way, unbelievable. And my good friend, Signor Raymond, in microcredits for 20 years, is achieving a lot. So you have, every time you have a crisis, every time you have disaster, you have very fantastic people in front of that. It should be the same in Lebanon. It has been the same in the French history. So let's try not to close the door, but open the door, go outside and fight and win. That's really the vision I have. And also to tell you that this house, Les Pensières, which is coming from my mother, and which is a holy house, is your house. So when you come, it's our pleasure. Even without science, if you are fed up with situation in your country, come and spend 2-3 days with us. It will be a pleasure. And Benedict knows that it's an open house for all of you. And please, once again, thank you for what you do. I admire what you achieve. And we try to be beside you, but not behind you, but always with you. Merci à tous et à toutes, et tous mes voeux pour ces 3 jours qui vous restent à travailler ensemble. Tout le meilleur. Merci.
So, merci. Thank you very much, Mario. So now we will move to the session of COVID-19. And it's my pleasure to introduce you the 2 chairmen. Graciela Russomando from Paraguay. She's a researcher professor at the National University of Asunción and researcher at the National Council of Science and Technology. And the second chairman is Dr. Daniel Bumucati. He's a medical virologist at the Rodolphe Merrieux Institute Laboratory of the Institut National de Référence Biomédicale in Goma. So please.
Hello. Okay. Good afternoon to everybody. We are happy to be here and to be invited for this session to be chaired with my colleague. from Republic of Congo. Yes. And okay, the session will be a little fast. At the beginning, we will have Jean-Luc Berland, 15 minutes talk. He will talk about the Gabriel Network in COVID initiative. And after that, we will have the presentation of the countries that are in the network of in COVID area. And each talk will be 10 minutes. And after all the presentations, there will be, I don't know how long, because it depends on how time we have, but all the questions will be after the presentation, please. So Jean-Luc Berland actually conduct operational research within the medical and scientific direction of Fundación Mérieux, focusing on epidemiological and surveillance studies conducted in collaboration with the Gabriel partners and with a particular interest in next generation sequencing technologies and its use in microbiological genomics. Please, Jean-Luc, we have 15 minutes.
Thank you for the introduction. So I will be short, and my job now is just to do an introduction of the next speaker about the five speakers from 5 members who are going to who participate to the initiative about the surveillance of the variants of the COVID-19. Yes. Okay. You certainly perfectly know these figures. This is the human toll. Now the distribution of the human toll according to countries and continents for now nearly 2 years. And despite the non-therapeutic measures and others, there are currently today still more than 3 million new infected cases weekly. So in the as any RNA virus, and Professor Lina talked about this morning, as an RNA virus, this virus shows or harbors some mutations, and in a very early time of the epidemic, and in the first quarter of 2020, some people already shows that there were some mutations, and in particular this aspartate mutation in position 614 to glycine, and that was shown first in Italian isolates, and within a few months, as we can see, they became the majority of the variants, and now represents nearly 100% of the variants, 99%, something like that, so the globally variants, circulating variants. And it was shown that this mutation was first in the spike protein, and also it's allowed, or it lets the virus have a higher rate of replication, and the titer of the viral load was much higher in the upper respiratory tract, so it's increased its transmissibility. And this is an example of the evolution of the virus. That was the first described mutation, but along with the evolution, then there are other mutations that we've seen this morning. And this is the time frame of how, an example in the United Kingdom from the covariant repository, how this variant become the majority in a very short period of time. So you see here from the originate variant in United Kingdom in a very few weeks, then the alpha became majority, and then now the delta is the only, almost only variant circulating in United Kingdom. And this, because of this increased transmissibility, the variants were named or variants of concern or variant of interest, depending on the properties. So variant of interest, then variants of concern. So these variants, you well know about that. They can pose some public health risks. And first of all, the increased transmissibility. The increased transmissibility means that there are more and more higher number of cases. And the higher the number of cases, the higher number of severe cases and the higher number of death. It can cause also some failure to be detected, and it was the famous alpha deletion in the alpha variants. It can escape to natural or vaccine-derived immunity, but so far this is not really this question, but it's not really a threat. And decreased in the susceptibility to therapeutics, and in particular in the monoclonal antibodies. And also we are afraid it can become more severe, it can develop more severe clinical courses. And so this is some well-known or major mutation that are associated, were shown to be associated with some phenotypic effects. All these 5 mutations are in the spike protein, and mainly the public health risk is from the higher and higher transmissibility. And as it was shown by Professor Lina this morning, it's not necessarily due to only one mutation, and we can see that the Delta variant here harbor this P6169181 position mutation, but it's probably a mixture of a pattern of several mutations that allow the higher transmissibility and other phenotypic effects. So don't focus only on the one single mutation. And so in very early of this year, in 2021, then Gabriel led an initiative, and from this first questionnaire, what was the information available in early 2021 about those variants? I believe, I mean, at that time, it was in February of this year, there were some countries with absolutely no data available, several countries. Then there were some known variants circulating. It was known in Lebanon. It was also known in China with this alpha variant, and also, of course, in Brazil, were at the time at the forefront of the fight against the COVID-19 and its variants. So the Gabriel initiative is about to set up some surveillance capacities in members who do not yet have their own program or are not embedded in another national program. This is what you are going to heard about in this session with the next talk. So from what was known at that time, why we decided to go to this initiative. So from a simple questionnaire, then the aim of the questionnaire was to confront the actions being taken by each of you, then to map the capabilities through the network and decide whether or not some action could be mutualized and were relevant to be developed. So from the answer that we received and we discussed during team meetings, we were used to that kind of tools. There was it showed that there were a large round of disparity and between the countries. In particular, some countries have a strategy from the Ministry of Health. Some do not have some strategy from the Ministry of Health, and they rely on initiative, individual initiative, rather than a clear nationwide strategy. And there was also a large round of disparity between members in terms of capacities. And I'm thinking from one side from China and Brazil that were they do the sequencing daily, and to other countries that were not prepared to that kind of work. But in fact, as there were some range of capacities, it appeared that all the required capacities to do some epidemiology about the variant, they exist somewhere in the network. And also there were a large spectrum of objectives. Each member of each country did not have the same objective, depending, of course, of the local epidemiology. Some countries cared about only severe cases. Some were seeking information about asymptomatic versus symptomatic cases. Some countries were caring about the travelers, the border that would come and with the infection with them, and some with particular settings, like in Mali, they were caring about the soldiers that were currently in operation in the countries. And also what showed that there were no funding to start a surveillance project apart from the independently of the MOH, and apart from Brazil, who already was on the road to make this kind of surveillance. And there were no links to other initiatives. Well, in early 2020, the initiative was only starting and were being put in place, but there were no links within the members with other initiatives. And I'm thinking that now what is running is the PGI program in the CDC Africa, funded by the Gates Foundation, for example. So it led to some priorities. First, the members need to find some local or regional solutions to access to some facilities. Remember that at that time there was some lockdown, and the traveling was much restricted. And so at least on the short term, to rely on the Gabriel network for bioinformatics, and also bioinformatics appear to be some scarce resource, and it is certainly something to work on it in the future, because it's something that is lacking to do some kind of genomics, and also to try to make the transfer the knowledge and to share the knowledge. Documents are nice, and all the members were willing to share their material, tutorials, and thinking about China and thinking about Brazil. They give everything that they had, but it doesn't replace the hands-on training. And certainly also this is that was mentioned this morning by Florence. This is something to work on, to seek for fellowship grants for the transfer of students or of staff from laboratory to other laboratory to increase the capacities. And also, of course, because of the different objectives, it seems to be more adapted to develop some specific plans to each country, to each member, rather than a multi-centric protocol, which will not cover all the issues of a single member. So next, the actions were decided. So first, to try where to start. The start was decided to target non-variants with the methods like real-time PCR or Sanger, where all the members are experienced, so it will be the fastest to start with, and also take this short-term time frame to not rely on or not to stand by sequencing, but to try to build the capacity of sequencing during this target detection, and to rely on Gabriel network bioinformatics capacities to try to gather some knowledge, and then only on the second time to seek some fellowship grants to go to the NGS capacity building, and to the long-term objective is, of course, to set some microbial genomics capacities beyond the COVID. And this is the logic of the intervention. So the first action should lead to enable the capacity building for surveillance of these variants. Then to get the baseline for the variant distribution. Then from this baseline, we can follow up with some change in the distribution. Then this again, then to embed it into health system, and it is the exactly what the remark of Bill Papp this morning. This is I believe this is a big task, a big ask to go from the laboratory results to the public health impact. And there's no, I believe this is important, and to go out of the laboratory and to build a teamwork that's as called this morning Bill Papp, to link the laboratory data with the metadata, the clinical data, the severity of cases, etc.
1 minute left, please.
Okay.
1 minute.
And 1 minute. Okay. And then also to set an efficient report process for the results to be known to the public health authorities. And of course, the long term, as I mentioned, the long term goal is to go beyond COVID crisis and to have some capacities to make surveillance for other pathogens. Okay, this is my almost last slide, and this is just the you can see the new infected cases from the countries that are participating to this initiative. So this is Bangladesh, Cameroon, Lebanon, and Madagascar. And you can see that still in October, November 21, there are thousands of new infected cases in all these countries. And here I let the floor to the members, and I just want to mention that people is essential. So in this initiative, there are also Florence that is involved, and Emily, that's I can't see her, but she's also involved with the members here. And I let the floor to I believe this is the Marianne, maybe now.
Thank you very much for the presentation. I think the floor will be to Marianne Abifadel, that you know very well, and because she was the chair in the last session, and for you will have also 10 minutes for the presentation.
Thank you. So I'm going to present the study implemented in Lebanon at the Rodolphe Mérieux Laboratory in Beirut, at St. Joseph University of Beirut. So this is the situation now in Lebanon. It's a rapid overview of the COVID-19 epidemic in Lebanon, with here the number of confirmed cases, number of deaths for 6 million living in Lebanon now between Lebanese and refugees. We have 30% or 30% of the population with the 2 doses of vaccine. And COVID-19 started in February 21 in Lebanon, and the first death was in March 10. And it was at this time that we started the diagnosis of COVID-19 in the LRM with the help of Fondation Mérieux, BioMérieux, and Monsieur Mérieux himself. For the first few months, the situation was quite okay, with successful management of the spread of the virus by imposing several lockdowns. But unfortunately, after the Beirut tragic blast on the 4th of August, the numbers started to increase as you can see here. And in December, we had the first case of a UK strain detected in a flight coming back from United Kingdom, and then the number increased. And due to the gathering at Christmas and the New Year's, we had very high levels, as you can see here, with more than 4,000 cases a day. We had shortage of oxygen and ventilators in hospital, and the peak was in mid-January, so 15 days after the end of the year, and with 6,000 cases a day, which is huge for a population like in Lebanon. And in January 21, we had almost 86 of COVID-19 regular beds and 92 of COVID ICU bed occupied, and it was a dramatical situation. And then we had the vaccine. No, so it began in mid-February. And as you can see here, it was a decrease of the number. And in June, we had only 66 reported cases a day. In the beginning of July, you had the new strains and the Delta strain, and a little increase in the number, as you can see here. For now, we have approximately 600 new cases per day. These two last days, we had a little bit increase for 800. So the LRM was the first private university laboratory to have responded to the call of the Ministry of Health by providing tests for SARS-CoV-2 since the beginning of March 2020. In addition to the laboratory of the Rafiq Hariri University Hospital, which is the governmental hospital, it was in charge of all the cases of COVID. The LRM supported also Hôtel de France Hospital and other hospitals across the countries in different regions of North, Bekaa, Beirut, and its suburbs in their diagnosis activities. And we worked with, in close collaboration with the Lebanese Ministry of Health and with other screening laboratories. And you have the list of all the accredited laboratories doing COVID-19's diagnosis in Lebanon. We participated, the team of the LRM with Fondation Mérieux participated in several diagnosis missions of the Lebanon and out of the laboratory and in several regions in Lebanon, in refugee camps across the country, in Baalbek, Hermel, Kobayat, suburbs of Beirut, for migrant workers in precarious situations in collaboration with AMEL situation, organization or association that you all know. In the region of Ras al Naba, it's near the faculty in Beirut, where an epidemic outbreak had broken out in a community of migrant workers in long-term facilities in several regions in Lebanon, in collaboration with ONG like Order of Malta in Lebanon, for Red Cross and several NGOs as well. I'm going to talk about, because we had a plan and all of us have tried to answer some specific questions sent by Jean-Luc. So for data reporting system and process in Lebanon, positive COVID-19 patients are reported daily to the epidemiologic surveillance unit of the Ministry of Public Health in Lebanon via a platform that you have the platform here, District Health Information Software. As for the sequencing, so in early January 2021, we revealed the presence of UK strain in different clusters from Lebanese region, Akkar, Bhabda, Shuf, Kesirwan, Matan, several regions in Lebanon. The results explain the important increase in the number of transmission, hospitalization, and deaths of COVID-19 positive patients in January and February in Lebanon. We sequenced by Sanger sequencing because it was we had not NGS. and it was to help raising awareness at the national level regarding the emergence and rapid spread of new strains in Lebanon and strengthening the prevention measures. And we reported our result to the Ministry of Public Health, but also the public through the internet site of the university and national press, as you can see here in Arabic and French as well. So from March 2020 until July 2021, we have studied around 48 SARS-CoV-2 positive specimens by sequencing the spike region, partially or completely, depending on the cases, by Sanger method, and it was done very quickly. We had the primers and we sequenced it rapidly, and we studied different clusters, long-term care facilities, COVID-19 vaccine breakthrough cases, and the severe COVID-19 in adults. And we know with the Gabriel network, we want to pursue the studies, we want to pursue the recruitment. These cases, we have a lot of cases in Lebanon. We selected only 48 representing several infections and clusters along the year. But now we're going to try, first of all, to study these strains by NGS with the help of the network, and also to study also other strains with a total of 300. And due to the limitation of the sequencing of the spike region by Sanger method, we believe that having access to NGS with the support of the Gabriel network is crucial for the continuous surveillance of the variants spreading in Lebanon. What we're doing is first Sanger sequencing. It will be used when rapid screening methods are not yet available or have to be completed by rapid sequencing of the spike. We also will screen using RT-PCR. It will be performed, and it is performed on positive SARS-CoV-2 samples belonging to the study group with CT value below 25. And we will perform 50 NGS, so NGS sequencing on 50 specimens that we selected from all these months. These are some preliminary results based on Sanger sequencing. We had at the beginning, as for all the countries, clade 19A, 20A, and here we had a huge amount of patients and the UK variant prevalence, which was important. And we have also some UK strain with rare mutation, never described in the region, and maybe with 1 or 2 cases around the world. And it was mainly in patients that have received the vaccine. We have also in July cases of Delta variant. And we're going now to do the sequencing, the NGS sequencing, and we hopefully will have the results until the end of the year. So we're going to share the data. The data sharing would be at the national level. All data and results obtained will be communicated to the ministry and the concerned organization, as we do on a daily basis. If the results seems important to help raising awareness at the national level regarding the emergence and rapid spread of new strains in Lebanon, we will publish it as we already did in January. At an international level, I think that sharing and comparing results between the countries involved in the study, Madagascar, Cameroon, Bangladesh, through the Gabriel network will help in establishing connection with dedicating networks. And of course, as stated this morning, if we can do more studies, maybe genetic studies or other comparative studies with metabolic syndrome or something like this, it will be great, especially that in Lebanon, we have too many cases of very high cholesterol levels and hypercholesterolemia. What is the expected impact? I think it will be the same for all the countries. sharing the results at the national level, increasing synergy between research organization, between capacity of governmental and non-governmental organization to link research policy and practice, and at the laboratory level, increasing capacity to do research, manage research, and to apply and share results of research and publish the data, but also to help student, master student or PhD student as well. This is the team with Monsieur and Madame Mérieux in June. And I would like to thank the Fondation Mérieux, BioMérieux, and also Florence, Jean-Luc, Émilie, and of course, all the network. Thank you.
Thank you very much. I think that the presentation ended on time. So if it was only depending on me, I wouldn't stop it because it was very nice. But thank you very much for being on time. The next presenter.
With us is Raza Molina. I will say your last name. Your first name is very complicated for me. He works at the laboratory as a technician in biochemistry laboratory at Antananarivo University Hospital. And he has, during his work, he was able to have a good experience in the field of relations with national and international partners. Thank you.
Thank you. So good morning, everyone, and I'm happy to be here to share our activities in the CICM Madagascar about sentinel surveillance of changes in variant composition and structure in Madagascar. In this slide, I will try to show us directly the overview of the COVID-19 epidemic in Madagascar. The entry of the virus was in March 2020. Cases was confirmed from passengers on flights from Europe. After that, few days after that, the authority decided to announce the state of health emergency to Madagascar. So regional and international flights were suspended, schools and universities were closed, and sports and cultural events were also suspended. In April 2020, despite all the measures that have been taken, the transmission continued. The department responsible of epidemiological and riposte announced a rise of cases, over 90 confirmed cases. The authority announced to maintain and reinforce the barrier gesture, and every 15 days there is an announcement of instruction to follow depending on the pandemic situation in the highlands. 4 or 5 months after, a decline in new cases have been observed, and it have been announced the end of the state of health emergency in Madagascar. Unfortunately, in the beginning of this year, the new cases started to rise. It was probably due to the opening of the traffic on the whole highlands and on holidays, and the barrier gesture are not well respected. In March 2021, there is an increased number of new cases, mainly in the north parts of Madagascar, and we were in the second wave of the pandemic. It was announced also that the South African variant was present in Madagascar. Madagascar is newly in a state of health emergency after this observation. The number of cases didn't stop to spread, mostly in the north part of the island, and we have a peak over 600 of new cases per week, and with number of deaths of 10 per week. And it was said that the month of April was the most murderous month at this time. In April, again, in this month, the authorities decided to close the most affected regions in the north area for Iceland, and also the highlands of Madagascar. In July up to August 2021, it have been observed the decline in new cases. The situation to date is that the number of cases is very low. In this map, we find that in October, 0 cases have been reported, and the end of the state of health emergency have been announced. In total, since the beginning of the pandemic, a total case of over 43,000 have been recorded, with number of deaths of over 900, which is, we think, very low compared to other countries. In Madagascar, the President of the Republic, with the Madagascar Applied Research Institute, produced a kind of medication which is supposed to prevent and cure the coronaviruses. The clinical trials, the results of the clinical trials that have been conducted by the Ministry of the Research is now under assessment by the committee of the WHO experts. About the vaccine, Madagascar have received the vaccine in May 2021. And you can see here that the proportion of fully vaccinated population is very low, with 0.7%. Maybe it could be linked to the late arrival of the vaccine in Madagascar, or to the hesitancy of the people. About the variants of SARS-CoV-2, as presented previously, we have the beta coronavirus in Madagascar, the South African variant. But for the Delta corona variant, this variant is not detected yet in Madagascar, according to the Pasteur Institute in September 2021. How the CICM is embedded in the national response. Since the beginning of the pandemic, the CICM participates actively in the PCR diagnosis of COVID-19. Here we have the total number of samples that we have treated since April 2020 up to the present day. Donc we have over 13,000 of samples. About the distribution of the PCR positive, this picture shows us the data from the second wave, which shows the frequency of symptomatic cases compared to the symptomatic cases, and the distribution age, which is focused on in the group age of 24 up to 48 years old. About the data reporting system process, all of the laboratories which works for the molecular diagnosis of COVID-19, the CICM, the Pasteur Institute, and the laboratory of the newly created by the government, use a single analysis request form. And after, for the CSM, we record the data in an access software. And all results are sent directly by mail to the Ministry of Health, and the directions are responsible for the prevention of preventive medicine and epidemiological surveillance and response. In addition to the COVID-19 diagnosis, the CSM is now planned to perform variant detection. And this is the study design that have built for this variant detection. So it will be retrospective and prospective sampling, in which we will select samples with positive samples with PCR and 25 in CT. And we will test with RT-PCR. We will do a screening PCR in order to look for the main variants if the PCR is positive. Sorry. And if the PCR screening is negative, we try to perform Sanger and NGS sequencing for the characterization of the samples. About the timeline, this table shows us the activities that we have performed and the activities that we will carry out. So now we are in the point where we discuss about the start of the variant screening. We expected to, in the results, we would like to identify the variants circulating in Madagascar, because as presented previously, there is only the variant from South Africa in Madagascar, but it was not published in the scientific paper. And we would like to correlate also the variant, the eventual variant with the clinical forms. For the data sharing, we work closely with clinicians in the hospital university. So once we have the result, we will directly share the results to them, and also to the Malagasy authorities, the Ministry of Public Health. Up to now, we don't have yet connection with any existing dedicated networks. So maybe it could be helpful if the Gabriel network will support us for this connection, because it is very necessary to Madagascar to have exchange of experience with other network.
5 minutes extra. So
thank you.
Maybe last slide, please.
Yes. For the expected impact, the expected impact goes toward the public health level and the laboratory level. And we have here the increased capacity to apply and share results of research for the public health level. And at the laboratory level, we have the increased microbial genomic capacity to perform research, and the registration of CICM as a stakeholder in research on COVID-19 in Malagasy clinician and scientific community. We have here the support of Gabriel Network, the financial support and technical support for the surveillance of SARS-CoV-2 variants in Madagascar. The blocking points for us is the NGS and the data analysis after. So we need training for these two main points. And before ending, I would like to thank to all of the team in the CICM of Madagascar, which is led by Professor Samson, and the team of the Fondation Milieu. We have Laurence Pratel, Jean-Luc, and Émilie Westel. So thank you very much for your attention.
Thank you very much. You were speaking with your heart, so it was very hard to stop you. But we are very happy with the nice talk. And it was 5 minutes extra. So we're gonna call Dr. Richard Njom from Cameroon and to present his activities. Dr. Richard is the research director and the head of virology department at the Centre Pasteur in Cameroon, and is a virologist, and he also is also a lecturer of virology talks in some other university in Cameroon and Western Africa, and he has a great experience in viruses, especially hepatitis and respiratory viruses. And so, Dr. Richard, I hope that 10 minutes will be enough for your talks. Thank you.
1 minute more.
Thank you. Okay, thank you very much. I would like also to thank the organizer, mainly Florence and all the teams. It's really a great pleasure for me to participate for the first time in this Gabriel meeting. I know that my colleague in Cameroon in the bacteriology part have already been member of this, but it's the first time I joined as a virologist. So I would like to present to you what is how the Centre Pasteur of Cameroon is involved in this project. As the other colleague said, I have to present it with the template that was given to us. So regarding the overview of the COVID-19 in Cameroon, the first cases was detected in Cameroon in March 2020, and it was detected by the Centre Pasteur of Cameroon. And since March 2020, we have already detected more than 100 confirmed cases, and with a case fatality rate of 1.7%. We see that regarding the vaccination rates, we are very low, as in many countries in Africa. And this slide shows the evolutions of the confirmed cases since the beginning, and Cameroon is now evolving through the third wave, because we have the first one at the beginning of the pandemic in June and July 2020. The second one was in February till April 2021. And now we are, let's say, going out of the third outbreak, because you see that as this result showed what is done last week, we have less than, about 5% detection cases in Cameroon. And as in most countries, Cameroon also have a very low testing rate, because according to the WHO recommendations, we have to detect about 10 per 10,000 inhabitants tested in the country. But we see that by using PCR or RDTs, we detect the detection rate is lower than that. So we need to improve detection rate in order to have many persons tested. At the level of the country, the contribution of the Centre Pasteur was very, very high, because at the beginning, we was the only reference laboratory was doing the testing, because we were the first to implement the test in Cameroon. And we were also thanks to Sarah Yango, who is here because he was the first was appointed as the, let's say, the head of the national unit in the diagnosis of COVID in Cameroon. And with her help and we are the colleague of Sarah, we were able to extend, to decentralize the testing. so that because Cameroon a very big countries and it was not easy to take sampling from the northern part to the southern part where the central lab is located. So we are able in, let's say, 6 months to decentralize the lab so that for now, we have a very big network of laboratories which cover all the 10 regions of Cameroon. And we have about 20 reference labs located in all the 10 administrative region of Cameroon. And we also developed, that is a very big information, we developed, let's say, at Saint Pasteur, a national database called PLACAR. And that's where most of the 20 labs in the country are registered their results, and also it's also used as a reporting database for the results to all the people who are traveling in the country. And lastly, this is when the variant started in the world. The Ministry of Health, let's say, developed a new platform called the Genomic Surveillance Platform in April 2021. And this platform is coordinated by the ministry itself. And we see that the Saint Pasteur of Cameroon is one of the members, because there are about 4 institutions in Cameroon that are involved, and the Saint Pasteur Cameroon is involved in this country. What have already been done so far with this platform is that we have developed the national strategy, We have developed the national strategy in Cameroon. We have also national strategy. And because this strategy was, the ministry set up this platform, the strategy was there, but there was no funding to start the work. That's why we are looking for funding. That's why we joined many initiatives. That's why we see that we were in the PGI, the repair is the initiative of the Pasteur Institute Network. We joined the AfroStream, and very recently the Gabriel. And so we were now trying to see how we can manage all of that, because finally we were involved in many networks. And because we have a, let's say, an annex of the Saint Pasteur in the northern part of Cameroon, and because we do not receive many samples from that part of Cameroon, we have decided that the Gabriel initiative will be located in the northern part of the country. That's where, because we have an annex of Pasteur, so we decentralize that aspect so that the sample in the northern part will be done there, and the Gabriel initiative will be done. We see that that's where we are involved, and the Gabriel initiative in Cameroon will be done in the 3 regions of Cameroon, and the 3 regions is in the big town, the capital, Garoua, Ngaoundéré, and Maroua, about 300 samples to be tested. And this is how the sample will be get from symptomatic to asymptomatic. We have not yet started. We are planning to start in December 2000 because of, we have already purchased the reagent, but we are waiting that this reagent arrives in Cameroon. And also we will get some basic and clinical data through the clinical record form that we have in the study. So this is our strategy for variant detection. So what we will do, this is what we are using for the screening in the southern part of Cameroon. So the same strategy will be, let's say, will be reported in the northern part where the Gabriel initiative will be developed. So samples which are positive with CT value less than 30, we'll first started by PCR screening, because that's all those laboratories have the PCR machine for diagnostics. So the samples that are VOC, we will select about 20% of those samples to do the whole genome, and the full genome will be, let's say, submitted to DZ. And those who are non-VOT will do in second time the partial sequencing, which will help up in the S-gen, which helps to know with the Wuhan strain, and those who are VOI or probably VOI, and we select all the VOI and the 20% of the non-VOI and the Wuhan strain will also go through whole genome sequencing. At the end, we have some of those full sequence that have to be submitted to the GIZET platform. So what we are expecting is that we get, let's say, a clear picture, mostly in the northern part, because we already have a picture in the southern part of Cameroon. We have already tested about 1,000 samples with, at the beginning, from January to June 2021, we have the alpha and beta. And since August 2021 is only the Delta recirculated in Cameroon. Also, we are planning at ACOM to have, let's say, inform the Ministry of Health, inform the scientific community, provided Cameroonian sequencing to GZ, and also to have this connection that have already been established with other network. And finally, we hope that the impact of this study will help us to build a real biobank, because some of the samples are missing. We don't have many samples of the northern part of Cameroon. We'll also use this strategy of detection so that it will be implemented in all those 10 laboratories, 10 regions of Cameroon, so that the first screening part will be decentralized in all the lab. And finally, the way of informing the ministry every week, so with the sample, with the results coming from all the 10 regions, will help to better orient the response of COVID-19 in the country. So I would like to thank all of you for your understanding. Thank you.
Thank you very much, Dr. Richard. And so I'm a little bit frustrated because you didn't allow me to do my job of timekeeper. So you finished 2 minutes earlier. So congratulations once more again. And we'll call Dr. Ferdowsi Kadri. Is she in the room? Yes. Dr. Ferdowsi is a big name that you may know, the head of mucosal immunology and vaccinology units of infectious disease, Dhaka in Bangladesh. She published a lot, more than 490 publications. And also she has been awarded for several times. So if I start just mentioning the awards, the time allocated will finish. Please, Doctor.
Thank you. Yeah,
please
I hope
thank you.
give you some time to stop me. Thank you so much. Good afternoon, and thanks to everyone for allowing me and my colleagues from IDESHI to come to this meeting. So I'm going to talk about some of the things that we are doing on SARS-CoV-2 and the work that we are doing with Florence and Jean-Luc and Emily with the variant PCR. So just a little bit about what happened in Bangladesh. Our first UK arrived, this first 2 people coming from UK, I mean Bangladeshis, were detected for COVID-19. And that is how the pandemic started in Bangladesh. And, so this brought a big burden on our country of 180 million people. We live very close together, especially in the cities. And the epicenter of this epidemic was Bangladesh in Dhaka city, and then it spread to Chittagong. We've had 3 waves of COVID-19, and the last wave was the Delta one that everybody's talking about from May to August, and still now whatever we are getting, it's 1%. It rose to 30% prevalence, and then it has come down to 1% now, but it's all the Delta now. So we started out in Dhaka, and then we had a great big holiday, a national holiday that people were asked not to move, but instead everybody took away from Dhaka and went to all over the country. And that's how we spread the COVID-19 all over the country. So we have until now, in November this week, 1.6 million people who have been infected with COVID-19 and 28,000 have died. The rates are much lower actually now, as I said, and death rates generally are much lower, even from neighboring India. We've had very good luck. We've been discussing with Bill and everyone why are we so low in deaths? And we have a lot of asymptomatic cases in Bangladesh and not at that many symptomatic. But as you can understand, in a developing country, we don't have very high testing rates. So we probably miss also. So I will put the hat on IDESHI now and not talk about ICDDRB. IDESHI is the foundation that I set up with the prize money that I got from the Christopher Rudolph prize. And that's how I started doing more things. And so it's we are doing a lot of work supporting the government. So when COVID first appeared in Bangladesh, there were only 4 labs that had BSL-2 facility Basel 2 facility, that means Basel 2 plus facility, in which you could do RT-PCR, extract the, and Aideshi was one of them. And just before that, I visited China in January, and I knew because I visited a Gabriel member, Zhen Yu, and I knew he told me there's a big epidemic coming, and because they were doing the sequencing. So I came back and fit up my lab. And so we now became the first to help the government among the private labs. And so we are doing the testing and also antigen testing, rapid antigen testing, and all this is fed into a management information system of Bangladesh. And we have a very good COVID-19 dashboard, which is called Shurokha. We test and immediately our result goes on into the dashboard. And we are also doing a lot of other things. We are looking at antibody responses, both in the population and in vaccine, COVID-19 vaccine studies in Bangladesh. We now have 5 vaccines in Bangladesh, although the vaccination rate is close to about 24% maximum. And we have the EUL for the Covishield vaccine, which is the AstraZeneca vaccine, Moderna, Pfizer, Sinopharm, and also Johnson & Johnson. So we have, whatever the country is trying to get, the 4 vaccines, Johnson & Johnson, haven't come in. And so what we're looking at antibody responses in the population as well in people who have been vaccinated. And with that, we can say what the levels are. And also we are doing in-house quantitative ELISA as well as commercial kits. And right now, the overall prevalence in Bangladesh in both urban and rural areas is 60%. And Bill and I can argue whether this is all that we need or we need vaccines. I think we need both. So for the first time, our group established the MinION sequencing, the platform, the very platform which we already had in our hands when the epidemic broke out. And we got reagents from Sanger Institute through friends and through Bath University. And as April 2020, starting from April 2020, we had used this platform, the Nanopore MinION sequencing, to sequence 500 SARS-CoV-2 genomes and then submit it to the GISAID. So a lot of the sampling that we've done and sequencing that have gone into the GISAID is from this platform. And this is connected to the IDCR, the national platform, from which we get samples and from which we integrate. So we have also a genomic consortium, and we are doing a nationwide surveillance with other funding and continuously informing the government about circulating variants. And we've also published in Nature Microbiology based on these results and using mobile phone network to show how the strains just moved all over Bangladesh. And we're also looking at all these other things. We are doing a lot of work in the Rohingya population with Valentina from the Foundation Merieux, and just also looking at the COVID-19 prevalence and antibody responses. It will be presented subsequently. And so this is how we are doing. And so we think that, with the variant PCR work that we are doing, we can have the variant analysis done in many labs in the country, which is very important because now we have MinION sequencing. We also have a few places which have the MiSeq Illumina sequencing, but these are far and few between. Whereas nowadays in Bangladesh, it's a big population. We have over 500 RT-PCR labs. And so every lab can do their own sequencing if they have the variant PCR technique available to them. So we think that, this is a very important technique that we are planning. We are going to work with BEAT-IT, which is where the Christoph Revolve BSL-3 laboratory is, and where they are going to do 300 strains. We are going to do 300 strains, and we are going to then use these strains to have 100 strains from both the 2 institutions and do the MinION sequencing on them. So we think that, we need sustainable funding to carry out variant analysis of PCR-based sequencing. This will be the platform on which we can plan later work. We need a lot of training and supervision from Foundation Merieux and the Gabriel Network, and we would like to make more connections. We will use extensive we need extensive bioinformatics support. I've been talking about it from the day I arrived over here, and Florence knows about it, and Valentina knows about it, and Jean-Luc also knows about it, that we must have, just doing the sequencing is not enough for any of our countries in the Gabriel Network. We must have more support, and we need to have continuous supply of reagents to perform MinION sequencing. I think for the variant PCR project, a surveillance strategy and sites of sample collection, we will, at IDESHI, we will collect samples that we get from IDCR, but we will also get samples. We have our own testing facility, so we get a lot of travelers who test in our facilities and also patients, suspected patients, and we will use these samples. So 600 samples will be analyzed over a 6-month period in the very carefully done bi-weekly calls. Jean-Luc and Florence and our team, we have been discussing this, and samples will be selected from the eligible nasopharyngeal swabs. You know that you cannot do sequencing on samples that are more than 27 or 30 because it does not allow you to sequence. And so we're going to do that, samples that are below 30. And then we will use these, we will include both, purposely include both symptomatic and asymptomatic cases, and then represent all age groups. And any sample which is below CT value 26, we will go on to nanopore sequencing at IDESHI, all the nanopore sequence, because we've become very adept and pro at the MinION sequencing with our genomic team over there. I think so. The design is similar to what other people have said. We will look at the clinical and epidemiological data, and we will then upload all the data into the GOB, Government of Bangladesh approved data collection form and case record form, and all the information from the subjects who are not present in data collection will be obtained later by a study communication team over phone, because all the time, all the data are not carefully collected in the national form. So we will call again, ask for more information on symptomatic, asymptomatic, and things like that. And we will also update our data electronically in the CASTR EDC system that the team has become trained in now over the last few months. And we will use the variant PCR and the MinION sequencing samples. And this will go on from August 2021 to June 2022. And so right now what we've done, we have a IRB that we have to get approval from, which takes time. So we've got that now. The protocol has been developed. IRB approval has been completed with the national institution. The bi-weekly conference calls are ongoing regularly. All the reagents are ordered and most of them are in hand now. And as soon as we go back, we will start planning on what actions to take. So we have also got lots of samples that are archived at the National Institute IDCR with the CT value below 27. So we are going to look at samples that are retrospective samples also, to look at the lineage of samples that meet the inclusion criteria, to get the picture of the circulating lineages in the country, and any emerging variant, as well as we will look at all the emerging variants, as well try to correlate the variant with disease severity, because we have the data, and it will be helpful to plan policies for vaccination and seroprevalence studies and all that. We will also be able to determine the prevalence of reinfection rates by each variant responsible for symptomatic and asymptomatic infections. And we will also be able to set up a baseline for a surveillance platform for the country. So there will be a lot of data sharing with national health governance to provide further interventions. Results are intended to contribute to decision making. We are going to work very closely with IDCR. In fact, the IDCR is also a co-PI of the study, and we'll work with the health authorities and upload our data into the Bangladesh genomic dashboard that is being set up for other national genomic platforms, and we will add to these platforms so that people are aware of what we are getting from the MinION sequencing and the PCR. So I think with that, we want to extend our training, the training that we do a training of trainers to other COVID laboratories in Bangladesh with future funding, and collaborate in Asia as well as in Africa. We had Cameroon and Madagascar talk about all the things they're doing, and so we will actually expand and hold hands. And this kind of a sequencing capability with PCR variant analysis will help us understand what's happening very quickly instead of waiting for NGS and Illumina and even a MinION platform. So with that, it will increase this project will increase our genomic capacity. We will, however, need increased capacity for bioinformatics. We will need to share results of research to national, international forum like this, and also wider forums. I think with this, we are getting a lot of capacity development of young scientists in our settings. I've got 3 young scientists with me today, and a lot of scope for further postgraduate training capacity. From one of these projects, we can have a master's student or a PhD student starting on. And so we believe that this Gabriel Variant PCR opens the door for increasing capacity for countries like us in the Gabriel network, and bringing cutting edge research practices very quickly. And it will be a state of art culture that we can adapt to not only COVID, not SARS-CoV-2, but I don't hope other things emerge, other viruses emerge, but when they do emerge, we will be ready, our labs will be ready. So with that, I would like to thank everyone, especially I would like to thank Florence, Jean-Luc, and Emily for the support they've given us, for including us in this consortium, and also for the bi-weekly calls and keeping us on our foot all the time. So I think without the Gabriel Foundation and the Meru Foundation and the Gabriel Network, she would not have been able to do so much. And so I think with that, I end. Time-wise, I'm okay?
And we gave you 2 minutes more. Okay, now we have an online video call, please. It's already? Is Dr. Shakil Ahmed from...
Hello,
Hello.
good night from here, and good evening to all of you. Thank
Shakil
you.
Ahmed from
Graciela
Bangladesh.
Kusamando. I am from Bangladesh, BITIT, Chittagong, and I'm very unfortunate that I could not join because of the government restrictions. And so I am joining from my office.
Okay, Dr. Hamed is in charge of supervision and quality management of all the molecular labs for COVID-19 diagnosis in whole Chittagong division. He's a supervisor of many research studies and students and author of many articles at national and international journals. Thank you, Dr. Hamed, for sharing with us your time.
Can you see my screen?
You have 10 minutes presentation, please.
Yes, can you see my screen?
Yeah. Yes.
Thank you. So I am representing Bangladesh Institute of Tropical and Infectious Disease, BITID, situated in Chittagong, and we are working with Gabriel in the SARS-CoV-2 variant screening. Bangladesh, you know, is a densely populated country of the world, and it recognized the first COVID-19 case in March 8 to 2020 by the IDCR. And as of the 6th November, yesterday, there are more than 1,570,000 cases and more than 27,000 deaths. And in our institute, and especially in Bangladesh, the basic medium for the diagnosis of this virus is RT-PCR. We are also doing the rapid antigen detection test, and we are also using the antibody detection for screening purposes. And till now, there are 5 COVID variants have been found in Bangladesh. The Alpha variant that appeared in the UK was first identified in Bangladesh on the 31st December 2020. Beta variant was that occurred in South Africa was obtained in January 24. This year, presently, Delta variant, also known as the Indian variant, is circulating predominantly throughout the country. And first case of the virus of this variant was identified in 20th April, and that is responsible for the very high 3rd wave in the country, which is now in the declining phase. And initially, the Delta variant were detected from the districts very close to the land borders with India, because people traveling from in the neighboring country were infected first. Now it is predominantly throughout the country, and we do not have any outbreak of Gamma variant. So far, including us, Bangladesh has sequenced more than 1,900 SARS-CoV-2 variants throughout the country on government and private levels. Among them, 91 were alpha, 41 were beta, 156 were 41 were beta, and delta was 156, and eta was 18. And there was this is the epidemiology of the variant studies in Bangladesh. And initially, what is our role? Actually, we started in BIGID, the COVID detection from the very early period. Initially, we provided support to IDCR because that was the only center from where the government allowed to do the PCR test. So we collected samples of passengers who are returning from China, and as early as in the 30th January 2020. And those were negative cases, and on 22nd March, we received reagents from the foundation, and I am very grateful to the Foundation Meru because when the commercial kits were not available, they provided us with the PCR materials, the positive control, the primer and the probe and everything. And on 25th March, we got the permission from the government, and we are the first center outside IDCR that is responsible for the detection of COVID-19. And now we are also doing the test for the passengers, and I am personally and the BIGID is responsible for overlooking the quality of all the PCR labs of the Greater Chittagong Division. And we daily input the RT-PCR data on the national data software, and at national level, IDCR is doing the regular variant surveillance study in collaboration with the IDESHI and ICGDRB, and at a regional level, Chittagong Veterinary University and Chittagong University is also doing variant surveillance study. At BIGID, at RML lab, we do not have the next generation sequencer, so we provide samples to them. We had provided samples to Chittagong University and Chittagong IDCR and Sivasu, the Chittagong Veterinary Animal Science University. We have provided them the sample, and we have collaborated them in the variant study. At present, we have no settings for variant screening and sequencing. And for this purpose, we need actually the support from the Gabriel, and they are already providing us the support. And we have archived the samples from the very March 2020 till today, and we will be doing the sequencing in collaboration with IDESHI in Dhaka. And share the expertise and tools and knowledge required for the implementation of variant surveillance. We are already getting the technical support, and IDESHI at Dhaka, Professor Firdausi Qadri, she just delivered before me, and they have got the Minan sequencing, and she has got the experience, and we will be sharing our sending our samples to them, and we will share the experience of doing this genetic sequencing. Currently, we had started a variant surveillance survey in collaboration with Foundation Meru and IDESHI, and we are also providing the national surveillance for variant study in the IDCR, and we are also providing them with samples. And the study that has been undertaken now, in the surveillance study, we will study 300 samples that will be obtained over a period of 12 months and randomly selected from eligible nasopharyngeal swabs that meets the inclusion criteria. And the sample will include both symptomatic and asymptomatic cases representing both sexes and all age groups. And also I shall see through it that it also represents the areas of different districts of Chittagong. And compassion to the metadata acquisition, the data will be collected through a pre-designed data sheet during the patient enrollment at the facilities. And the viral RNA will be extracted from the nasopharyngeal specimens using commercial genome kit, and circular cDNA will be synthesized and will be used for the RT-PCR and variant study VOC and VOI by RT-PCR. And from that positive results, about 100 SARS-CoV-2 positive specimens having CT value below 27 will be subjected to whole genome sequencing with Oxford Nanopore technology. The team will follow the internationally adopted Arctic genome sequencing protocol. Raw data will be generated and base called using the Minian sequencing, and consensus genome will be generated and uploaded in public sequencing database such as GSA, GenBank, and ENA. And the timeline is 1 year, July, and we have already got the institutional ethical review permission from IDCR, and we have already procured the kits, and it is now available, and we have started doing the screening for variant study. And the expected results and outcomes: identify the lineage of any single specimen meeting inclusion criteria, get the picture of circulating lineages in the country, capture any emerging variant, correlate variant with severity and disease state, because we will have all the clinical data also, capture reinfection cases. After completion, we can share our variant surveillance findings with our local and national authority for further interventions. Currently, we do not have any contact with IDCR. We are in contact with IEDCR and IDESHI in Bangladesh regarding the surveillance study, and there is a national surveillance going on in addition to this Gabriel network survey. But we do not have any other external linkage other than the Gabriel network. And the impact will be both in the laboratory level as well as in the public health level, increasing synergy between research organizations, increase capacity to apply and share results of research, increase capacity of government and non-governmental organizations like for research, policy development, and practices. And at the laboratory level, we will have the increased capacity to do research, increased capacity to manage the research protocols, and increased capacity to apply and share the results of the research. Especially, we are lacking in the field of publishing our data in international journals. So we want to improve this situation. And we are also taking students for their master's and PhD programs and internship done as part of this curriculum. Thank you very much. Thank you all. And thank you, Jean-Luc and Florence, for their kind support. And thank you all the audience. Thank you all.
Thank you very much, Dr. Ahmed. And we have had all our presentations, I think 6 in total, and we'll go for a quick tour of questions regarding all presentations. Please, may we know if we have online people for questions, but we'll start first with in person. We do have some questions here, and we can specify the person to whom the question is addressed, please. I know that we have 10 minutes before coffee break, so it will be enough for taking some questions. The first one is from Florence. Yes.
Yes, thank you. So I have a question for Mandrant, Madagascar. Mandrant, you have mentioned that during the second wave, you have more symptomatic than asymptomatic in terms of positivity. And I'm wondering if this is due to your the sampling strategy. Do you know if sampling focus only on people that have symptoms, and that can be explained why you have a difference in
Thank you, Florence, for this question. Of course, I presented that symptomatic were frequent compared to the asymptomatic cases during the second wave. The explanation of this observation is that during the second wave, the clinicians in the hospital university found that most of the patients have different, have of a clinical form, which is different compared to the first wave. And they prefer to send their samples to the CSM. And for the CSM, during the second wave, we treated most of the samples from the hospitals, and maybe that's why we have a high number of symptomatic cases compared to the asymptomatic cases in our data. Professor Samson?
Yeah, I would like to add an explanation of that. In fact, it's the strategy of the Ministry of Health that has changed between the first wave and the second wave. For the first wave, they would like to test everybody because it was at a low number at the beginning. But during the second case, there was a lot of cases, and the number of PCR tests are not enough for all the suspected cases. So they only wanted to test all symptomatic cases. That's why there was a difference between the enrollment. Thank you.
I have a question for Lebanon. Are you thinking about a surveillance system from now and up with a multiplex real-time PCR, including COVID plus another pathogens, respiratory pathogens for the near future? And a question for Bangladesh presentations. Are you working in a national surveillance, genomic surveillance system, or you will work in different places for genomic surveillance? This is because it was considered that to increase effort, the variance analysis with RT-PCR could be nice if you work all together, and then all these, the negative ones, you can use all together in a national surveillance system. So please, thank you.
Yes, of course, we're doing so from I think 4 or 5 months or so. We're doing with BioFire, and we're trying to know what exactly we're finding other than COVID now. I mean, for severe cases of parainfluenza or even other rhinoviruses, etc. So at the moment we have only COVID, and now we show that, yeah, other virus.
There was a question for Bangladesh. Yes, please.
Okay, so from Bangladesh, we work with the National Institute IDCR, which is responsible for COVID surveillance and all types of surveillance. And BTID is also a government laboratory. Although it has the Christopher Rolfe laboratory over there, it's a government organization. So for IDC's role is to hold hands and bring everyone together. So we have investigators from the IDCR with us, and it's always a capacity building and sharing of information. So for MinION sequencing, we did the same. For variant PCR, we are doing the same. And for Illumina also, we are doing the same. So it's capacity building of the government, information sharing with the government always.
Okay, do you have additional questions in the room or online? Amongst people who are connected, no question? Yes, one question, please.
Thank you for the beautiful presentations. And I was wondering if, beside the virological studies in your laboratories, are you planning to do immunospecific studies, for example, beside the serology, also T-cell based studies to detect T-specific responses against SARS-CoV-2, because this may be useful, for example, to monitor the response to vaccines once they will be delivered in your countries, and to evaluate the persistence of these responses. And this could be particularly important in patients with immunomediated disease, like HIV-infected individuals or people under biological therapies and so on.
Thank you for this question, because what we are doing is looking at the immune response, both the adaptive response and the innate responses. We're looking at the response, both the adaptive and innate responses, B cell and T cell responses, affinity of antibodies, isotype subclasses of antibodies, but we're also looking at vaccine responses so that we're comparing. And also we had one question that what happens when you have COVID and then you have vaccine? We have seen that at least 4 to 10 times higher antibody responses, even from Covishield, which gives us the lowest response. So we are doing that a lot. And to understand vaccine escape, mutations, and at the same time, we are doing the genomics of these strains. So until now, we've looked at different severity of COVID when we had the beta variant. And then we extended that into the Delta variant. We have now data from beta variant, a lot of what happens when we have the beta variant for circulating in all grades of diseases, asymptomatic, symptomatic, mild, moderate, severe disease, and healthy controls at the same time, because we wanted healthy controls because now the seroprevalence levels is like 60%. So we wanted to know the difference. And so with this, looking at both sides of the spectrum, we can understand how much the vaccine contributes, how much natural immune response contribute, and what happens to the asymptomatic people. Are they actually going to be protected? We don't know actually. But we know that 100% of asymptomatic people also respond with antibodies, but the great level of antibodies are much lower compared to moderate and severe patients. And we know there's also the T cell responses to the SARS-CoV-2 antigens. The Ames response is very high in severe patients. We see definitely the severe and moderate patients have a spectrum of response which is much higher than mild or asymptomatic cases.
Because these evidence are present from the Western countries. So it would be wonderful to read it from India, Bangladesh.
So we have actually submitted a paper on just the full spectrum of antibody in patients, but we are also doing the more detailed T cell studies which are coming out, and also the Delta variant now. So we're not stopping. Thank you.
Okay, thank you. Yes, no additional question. I think that the time of coffee break is there. Yes, we just give a quick summary of different talks. I think that Jean-Luc Berland talked on the distribution of COVID toll, and so he showed us that the main mutation were on the protein S, and that impacted the transmissibility, the detection system, and some escape for nature of vaccine-derived immunity, and also that decreases at some point the susceptibility to different therapeutic. And so he ended by the priority for sequencing that should be based on the sequence access, bioinformatics, and also some fellowship grants for building capacity, etc. And also he insisted on the fact that we need to adapt our action plan. And then Marianne talked on Lebanon situation, starting by the small proportion of vaccinees with the second dose. And so the key issues we have for all LMIC countries, the lack of oxygen during the time of webs, and also the high case fatality rate. And so the involvement of Rodolphe Mérieux lab and the Ministry of Health in the COVID response regarding different aspects, for example, data reporting, surveillance, and sequencing, and also the need for NGS support in Lebanon. That was a call at Gabriel Network. And our colleague from Madagascar, Taina Mandrato, so yes, I've succeeded, yes, was able to present the background of the epidemiological situation. And he has also mentioning the COVID organic, yes, experiments ongoing right now in Madagascar, and also the very poor vaccination coverage, 0.7% of people fully vaccinated, and also he presented circulating variants, and he showed the impact of the Centre d'Infectiologie Charles Mérieux with PCR detection, data management and reporting, also the connection with the Minister of Health and surveillance system, and variant detection as well. And so he also focused on the need to connect with some other laboratories to receive support, especially on NGS. And Dr. Richard from Cameroon also depicted the low detection rates via PCR or RDT in Cameroon following WHO recommendation. And also he has shown and highlighted the impact of Pasteur Institute in Cameroon during the response activity. First, by decentralizing COVID diagnostic activities, especially in the northern parts of Cameroon and other regions. The development of a national database that called PLACA, and also the creation of a genomic platform with the Ministry of Health. And in that platform, or some new strategy of surveillance should be determined, and also the schema of variant surveillance. And so Dr. Ferrossi also talked about the weak detection capacity, and so that was improved through RT-PCR detection and RDTs, antigenic RDTs, and also the evaluation of antibody response in population. So need to compare seroprevalence and also immunogenicity of vaccines that were administered. And also they set up the Minion capacity with more than 500 genomes in the GSAID. And the request was to continue the variant surveillance, the RT-PCR testing, some training and supervision, especially Fondation Mérieux and the Gabriel Network, and also some extensive bioinformatics and reagent and support for Minion sequencing. And the last talk was from Dr. Shakil Hamid, and who depicted the epidemiologic situation of Bangladesh with more than 27,000 deaths recorded since the start of the outbreak, but also 1,900 sequences given, and also the implementation of RT-qPCR in Chittagong division, and the data result which are uploaded at the national level, and the variant surveillance system which has been set up. These are the summary of what has been discussed here, and we want to thank you with Dr. Graciela. Graciela, thank you very much. Yes, I was successful to pronounce his name, so it's not very, very, very tough to do. Thank you very much, and have a nice coffee break.
Thank you very much, Daniel, for this nice summary. So we have 25 minutes of break before to start for the next session for the young scientist presentation. Thank you. So please, now we will start the last session of this day, the Young Scientific Award session. So it's my pleasure to introduce the two chairwomen of this session, Sarah Eyango from Pasteur's Centre in Cameroon. She's the scientific director of Centre Pasteur, and she coordinates activities on research, public health, and environmental control in relation with national or international agencies. And Nathalie de Rekener, she is a medical doctor and an epidemiologist, currently working as a medical and public health advisor at the Mérieux Foundation that she joined in September 2021.
Thank you. Thank you. Good afternoon, everybody, and welcome for this last session. I think we are more than happy to chair the session on Scientific Young Scientist Award. This session, as I said, is dedicated to the presentation of Young Scientist Award. So it's really interesting for these young people to go to competition, to show the interest of their work, to show the innovation of their work. So they will have 10 minutes for presentation and 5 minutes for question. Please try to ask them relevant questions so that they can really show the relevance of their work, the quality of their work. So it is a competition, and the award will be given on Wednesday. So thank you very much. So the first presentation will be online. Fatima Rodriguez from Paraguay. So she is the young researcher at the microbiology department of health science research. She is currently doing her doctorate in biological science on the molecular epidemiology of methicillin-resistant Staphylococcus aureus. So you have 10 minutes for your presentation. Thank you.
Good afternoon. My name is Fatima Rodriguez, and I had the honor to present the work we do in the IICS, oriented to identify methicillin-resistant Staphylococcus aureus clones that cause invasive infections in Paraguayan children. Next, please. Our local network includes pediatricians, microbiologists, and molecular biologists of the most important hospitals in our country. Why do we study?
Please put the diaporama, and you are the one to move your slide.
It should be in slide mode.
Yeah, you need to put in the slide mode, and so to project, I don't know how to say in Spanish.
No está en la forma de presentación de slide, Fátima.
Tienes que compartir tu pantalla completa.
Eso.
Okay,
Ahora
thank
sí.
you. Ahí.
Gracias, Graciela.
Ahora se ve bien, si querés comenzar.
I guess this is the last one. You should go from the beginning. Yes, from here. You need to project. Please go.
Okay.
Another time, because it's not projected.
Otra vez, Fátima, si le das compartir pantalla.
Ahí está. There it is.
Ahí está.
Okay.
Very good.
Ahora sí.
Perfect, thank you.
I begin again or continue?
Continúa nomás.
Okay, next, please. Right. Why do we study methicillin-resistant Staphylococcus aureus? Because it is a pathogen declared of high priority level that can cause treatment refractory infections with high mortality, for which new antibiotics are urgently needed. It can cause a wide range of infections such as skin and soft tissue, foodborne eyes, necrotizing pneumonia, sepsis, acquired in the community hospital, or even livestock contact. Information on this pathogen in Paraguay was scarce. Next, please. This cross-sectionally study aimed to identify methicillin-resistant Staphylococcus aureus clones that cause invasive infection in Paraguayan children from 2009 to 2019. We had access, next please, we had access to the epidemiology file and antibiotic susceptibility test of the all isolates methicillin-resistant Staphylococcus aureus included in this study. Next, we performed the following molecular analysis, such as virulence factors and methicillin-resistant genes, and multiple locus variable analysis. Next, cassette SCC-MEC type, SPA typing, multiple locus sequence typing, and the detection of its clonal complex. Next, please. We analyze 85 methicillin-resistant Staphylococcus aureus isolates that cause invasive infections such as sepsis, necrotizing pneumonia, and osteomyelitis. The increase, next please, the increase in antibiotic resistance used as an alternative to methicillin resistant, such as, please, next, such as clindamycin and erythromycin, over the years was statistically significant. Next, please. Next. The most frequent virulence factors detected in our study was enterotoxin O, M, N, and U. Next, even if they are mainly associated with staphylococcal food poisoning, next please, they could be markers of specific methicillin-resistant Staphylococcus aureus virulent clones. These enterotoxins are considered superantigens that activate the disease. Next, please. More than 55% of the isolates analyzed carry the Phantom Valentine leukocidin. This virulent factor is an exotoxin responsible for rapid, severe and fatal soft tissue infections and necrotizing pneumonia in healthy children due to its ability, next please, due to its ability to destroy leukocytes with the consequent necrosis of tissues. Next, please. The major clones identified in this study was the clonal complex 30, sequence type 30, hepatite 019, corresponding to the most frequent isolates in a community environment in our country, reported in previous study by our research group. The circulation of these clones was displaced the others over the years. Next, please. Next, the second clone more frequently detected was the clonal complex 5, sequence type 5, hepatitis 311, associated with severe infections in the community in South America. Next. We detected other minor clones are closely related to the major ones with only little difference in the sequence caused by deletion or insertions due to chronic infections. Next slide, please. In conclusions, next, please. In conclusions, the most severe infection registered in Paraguayan children is associated with the Southwest Pacific clone, clonal complex 30, sequence type 30, hepatitis T019, caused for all the isolates analyzed carried at least one virulence factor that could aggravate the infection. Next, this work was possible thanks to all the members of our research network. Next, please. We thank to the Gabriel Network and Merieux Foundation for this opportunity to share our work with you. Thanks.
So thank you very much. So, that is a good point. You respect the time. One or two questions.
Thank you for your presentation. Concerning the sensitivity to antibiotics between your strain, you have someone had intermediate or resistance to glycopeptide?
We had susceptibility resistant to glucosides less than 50% of the isolates, less than 50% of the isolates. All isolates analyzed in this study.
Okay, another question, yes.
Yes, thank you very much. Maybe I missed it, but what is for you the definition of invasive infections? And did you observe any gradient of severities or maybe mortality data on this small cohort?
Because all of the isolates was isolated from sepsis, pneumonia, or another type of severe infections. In the from biological materials such as blood or another types of liquid from the course generally are sterile.
Okay, so you collect your sample within 10 years, from 2009 to 2019, I think, but we really didn't see what was the repartition of these strands, resistance along the years. You didn't mention the year of collection during the presentation.
Yes, in the graphic that I showed, I show the resistance by the years increased statistically significant only in erythromycin and clindamycin. The test, the susceptibility test by the others antibiotics didn't present statistically significant difference through the years study in this work.
Okay, thank you very much for your presentation. Thank you very much. Keep motivated. We will have the results on Wednesday. Thank you very much.
Thank you.
So the next presentation will be given by Zanat Kauser. So she's working, she's a resident medical officer at the Lab Cardiac Hospital in Bangladesh, and working at the Institute for Developing Science and Health Initiative. So you have 10 minutes for your presentation. That will be followed by 5 minutes of questions. Good luck.
Thank you so much. I am Dr. Zanat Kauser. Thank you so much for having me and for giving me this huge opportunity. Today, I'm going to present my study entitled Evaluation of Saliva as a Non-Invasive Alternative Specimen for Detection of SARS-CoV-2. We know that from the very beginning of the pandemic, there are several factors that we are facing as problems for our country as a developing one, including them accessibility and costs of clinical testing, shortages in the supply of materials and reagents such as viral transport media, nasopharyngeal swab, and personal protective equipments, and so on. Again, requirement for trained operators to collect the nasopharyngeal swab sample. Collecting saliva as a non-invasive and alternative specimen can minimize the exposure of the healthcare workers who are collecting the samples. A recent Yale study reported the saliva viral load is a better predictor of COVID-19 severity than the load from a nasopharyngeal swab testing. Many studies have been done so far to see the feasibility of saliva as a means of testing for COVID-19, including in them ICDDRB, one of the international research organization in our country, along with the IEDCR, which is a government, the National Reference Laboratory, with the USAID's Alliance, conducted one study enrolling 596 participants, and they found the saliva specimen to be 80% sensitive. And in another study, they found the saliva in 2021 around 90% sensitive. And it has been many other studies have been conducted around Bangladesh, such as in India, they found 100% specificity in saliva and 91% sensitivity. Similar viral load was also determined by CT value for ORF1ab gene and NE gene in paired specimens. However, these studies only based on samples tested at a single time point. So my study hypothesis was set as the saliva will maintain clinical performance of over 90% sensitivity relative to the NPS samples as a reference method in adults. And so my objectives was to determine the sensitivity and specificity of saliva RT-PCR compared to the NPS RT-PCR in symptomatic and asymptomatic individuals. I also set my objective to compare the receptor binding domain specific antibody responses with the saliva RT-PCR results. Regarding the methodology, I collected samples from 30 symptomatic, 30 asymptomatic, and 30 healthy controls. And I collected paired nasopharyngeal and saliva samples on day 1, day 7. And in this way, at 7-day intervals, up to until negative in both the samples, and on day 30. ELISA was done, and for this we collected blood samples from the participants from 30 symptomatic and asymptomatics on day 1 and day 30. We measured IgM and IgG from blood, and secretory immunoglobulin A will be measured from the saliva samples. All of us here more or less know about the methods for RT-PCR. In brief, viral RNA was extracted using the magnetic bead-based Nexor 32 fully automated extractor machine, and a positive test was set and at a threshold cycle of less than 40. The RBT specific IgM and IgG antibody concentrations were measured, and it will be correlated with the concentration of secretory IgA in saliva. 500 nanogram per ml was set as the positive cutoff value for both the IgG and IgM. And we also compared the presence of serum SARS-CoV-2 specific antibodies in patients who had previously tested positive on saliva and or swab samples RT-PCR analysis. Here are the study outcomes, starting with the demographic characteristics. Among the 60 cases, which the age ranged from 18 to 65 years with a median of 42. Among them, 31 were female and rest were males. The 30 symptomatic individuals had the common typical COVID-19 features like fever, cough, headache, generalized weakness, and others. The viral detection in nasopharyngeal swab and saliva sample among the symptomatic and asymptomatic participants has been shown here. Number of positive cases have been plotted against the various day points from day 1 to day 30. Here, as you can see, the blue lines represent the NPS and the red line represent the saliva RT-PCR results, and the number of cases for NPS on day 30 on day 1 were 30 in both the cases, whereas for the saliva 28 in the symptomatic group and 27 among the asymptomatic group were positive. And in this way you can see that the declining pattern of RT-PCR result on the increasing day points are similar for both the NPS and saliva samples. We determine the sensitivity of saliva samples in relation to nasopharyngeal swab. For the symptomatic cases and the asymptomatic ones, we found that from the p-value, we can say that the difference between the NPS and saliva sample on different day points were statistically non-significant. More than 90% sensitivity was noticed on day 1 of the saliva samples, whereas 100% sensitivity was seen on day 7, day 14, and day 30 in both the symptomatic and asymptomatic groups. 100% specificity of saliva was determined in relation to testing samples from 30 healthy controls in relation to NPS samples. And all the 5 discordant NPS samples discordant with the saliva sample PCR result had CT values above 36. The average CT values on different day points from both saliva RT-PCR and the NPS RT-PCR were also similar in all the day points during the time course of illness. From day 1, it increased from 27.2 up to 36.1 and 36.9 respectively on day 30. Here also you can see the similar pattern of increasing CT values. Regarding the serological response, the IgG antibody titer to RBD were positive in 65% of infected individuals on day 1, which subsequently increased to 96.5% on day 30. The IgM antibody titer to RBD was positive in 51.6% of infected individuals on day 1, and the finding was similar on day 30. The optimization for ELISA for measuring the mucosal secretory IgA to specific to RBD from the saliva specimen is ongoing and will be tested and correlated with the serological responses. Here, if we break down the IgG responses into symptomatic and asymptomatic groups, we can see that around 63% of positive cases on day 1 increased to 96.6% on day 30, and similar observation was seen for the asymptomatic groups. In conclusion, I want to say that there was sustained IgM and rising IgG seropositivity was observed in 50% and over 90% of individuals respectively, with a month's follow-up after exposure. And the saliva maintained clinical performance of over 90% sensitivity relative to the NP samples as the reference methods in adult patients. The study results indicate that the saliva is as effective as NPS for the identification of SARS-CoV-2 in symptomatic as well as asymptomatic individuals. Again, the use of self-collected saliva can improve the patient compliance and satisfaction, particularly for the surveillance testing for COVID-19, where repeated sample collections are necessary. And it was also seen that its stability at room temperature, the stability of SARS-CoV-2 in saliva at room temperature for at least 24 hours, further yielding its potential for collection at home. The feasibility of saliva sample collection may result in faster detection at a lower cost, as well as the self-collection of sample is possible, but it cannot be done with the NPS samples. The specimens, however, with CT values in RT-PCR higher than 36 may be missed by saliva RT-PCR. So my future recommendations will be that saliva specimen evaluation should be done for the pediatric as well as geriatric age group. The RDT evaluation using the saliva specimen needs to be studied, and the determination of cost-benefit ratio of saliva versus NPS as standard RT-PCR sample as I have found in my study that we can save about $6 for not using the logistics like VTM, swab sticks, and PPE. The determination of correlation of the saliva viral load with COVID-19 disease severity and hospitalization again needs to be studied. I would like to thank all my collaborators from the Mass General Hospital and ICDDRB who supported me a lot. And I also thank the Foundation Meru and Gabriel for giving me this huge opportunity to present my work in front of all your excellences. Thank you.
Thank you. We have 4 minutes for question.
Okay. Thank you for your presentation. I have many questions, but I will make only one. What is day one for you?
Day one for me
Yeah.
is the for the symptomatic cases within 5 days of symptom onset. Within 5 days of symptom onset and got their RT-PCR positive result for the first time.
And how do you explain that 65% of your population has a positive IgG in 5 days of infection?
Yes.
Those are reinfections, probably, yes? Or what are they?
Actually, in Bangladesh, the baseline titers has been done also in the other studies also. And the baseline titer was very high in Dhaka city, and almost all of the participants I enrolled in my study was from Dhaka city, and we have seen that in slum area also the baseline titer was pretty high and around 75% in the slum population. And many participants, almost 50% of the participants were enrolled after the start of the vaccination in our country in February 2021.
So they were infected after vaccination.
Yes, even after vaccination, they were infected.
Because it's important to show that, yes, that you got a 65% of IgG
Yes.
in less than 5 days
Yes.
of infection. So
Yes.
to discriminate that they are people not first infection, or probably they are after vaccination, yes?
Yes.
This will be understandable. And the second, this is the first work that I see, even in networks that I am, that you get like more than 90% of sensitivity in saliva and in nasal swab. So I think that is very, very complicated, and the first time that I see that.
Yeah.
Yes, we should be done that for many, many months before if it was like that. So my question is, do you know what kind of variant was circulating by that time? If probably this was Delta or something like this that has a large amount of mRNA in the fluids, probably.
Yes, the participants were enrolled from the duration from the starting day or date was October 2020, and it ended in October 2021. So a few of my samples were sequenced, and for few we had the beta variant, and for the rest of the samples that were able to sequence was Delta variant, beta and Delta.
Probably I missed in the methodology. What kit did you use, or did you perform a homemade tests?
The commercially available kits were used for RT-PCR. You are asking about the RT-PCR kits, or?
Virology tests and serology tests.
Okay. For the RT-PCR, we used the commercially and the approved government approved test kits in Bangladesh, And for the extraction, I mentioned that the automated extractor was used. And the kit that I have used had the cutoff value 40. And for the ELISA, we did the in-house ELISA method, the concentration method.
Abdul Salam.
Thank you. Did all the participants of your study the sampling of saliva in the same manner?
I'm sorry?
Did all the participants of your study give the sampling of saliva in the same way?
Yes, the saliva. Yes, they all the saliva samples were self-collected in a plastic container for all the participants.
In the front of you, or they sent to the lab after the sampling?
Okay, not in front of me, but the medical technologist and medical assistant, in front of the medical technologist and medical assistant who were collecting the nasopharyngeal swab. In front of them, they gave the saliva samples.
It's important.
Daniel?
Thank you very much. And Dr. Zanath, first, congratulations for the great work you did. And so I'm so excited to learn what you did. And that means, and soon and very soon, you will not need MTV anymore, according to your study. And
Yes.
so I think that you will need to deal with manufacturers soon in the world. They will be looking at you because they will miss some money. And my question is, I would like you, maybe it's a proposition as a prospect, you to compare the sensitivity of your RT-PCR test, maybe to try like GeneXpert, and to see if the performance is still the same. If we use a standard RT-PCR and, for example, GeneXpert, which is a more sensitive, ultra-sensitive PCR, maybe that this will change the performance you have observed, and that's we can move from one way or to another. It will be helpful for you. Thank you.
Thank you so much for your suggestion. I will note it down.
Thank you. Let's move on to the next speaker.
A very quick question. What is the volume that you need of saliva to perform the test?
I'm sorry.
What is the volume that we need to perform the test?
The amount of
Yes,
the amount
yes,
I
the
collected.
quantity, yeah.
I collected 3 ml of saliva. 3 ml.
No, but the RNA extraction.
Oh, for the RNA extraction, yes, 200 microliter. I collected 3 ml in the container.
And is it easy to collect 3 ml of saliva?
For the adult participant, all were adult, I collected the saliva specimens. And if the saliva were not, 3 ml was not possible to collect, as I need only 200 microliter, and I kept it open in my protocol that 1 to 3 ml saliva can be collected.
Thank you. Let's move on to the next speaker.
Thank you so much.
Elizabeth. Elizabeth Sogodogo from Mali. So Elizabeth is a pharmacist. She has been working on the detection of methanogen in the oral sinus flora. And since now 2020, she has been working on emerging pathogen and oral cavity pathologies at the Charles Varieux Infectious Disease Center in Bamako. You have 10 minutes.
Thank you. Hi, everybody. My name is Elizabeth Sogodogo from Mali. I've been in the microbiology researching in Saïsem, Mali since March 2020. I'll talk about my project, Microbiological Profile of Facial Cellulitis Cases in Mali. Cellulitis, what is it? Cellulitis is a microbial infection of the skin and underlying tissue and can be life-threatening. In developing countries, facial cellulitis is still widespread with very high prevalence. facial cellulitis represent 5 to 12% of consultation in odontostomatology. Here you are a photo with of a woman with cervicofacial cellulitis. The management of facial cellulitis in Mali is very difficult and leads to numerous deaths, particularly in the stomatology and maxillofacial surgery department, CNOS, which is the National Center of Odontology in Mali. In general, cellulitis of dental origin is microbial. Oral cavity of human is inhabited by several hundred species of bacteria and others microorganisms, including unicellular, eukaryote, prokaryote, fungi, and archaea. In dental microbiota, other microorganisms, including methanogen, in particular Methanoperibacter euralis, are involved in periodontitis, including in several forms. In a preliminary work at the CNOS, in 31%, methanogen were detected by molecular biology in the abscesses of 8 patients. Our hypothesis is a specific microbiological profile is associated with cervicofacial cellulitis in Mali, and knowledge of it promote better patient care. Our primary objective is to study the microbiological profile of facial cellulitis cases in Mali. We have 2 secondary objectives. First, to detect and isolate microorganisms in biological samples. Second, to determine the resistance profile of bacteria and fungi. My presentation is divided into 2 parts. First part is a detection and isolation of bacteria, materials and methods. We have a 3-site study, CNOS, CICM, and IHU. Our study period is scheduled as follows: August 2020 to August 2022. Here are our activities in Bamako. The time collection period is between 5th August 2020 to 20th October 20. 80 samples were collected among others, 79 cases of facial cellulitis and 1 case of NOMA. Different samples were collected with a swab of syringe by picture performed by a surgeon. We use different media in laboratory. The bacteria are identified by VICTEC2. Here, our activities in Marseille. The time of period of stay is 5th November 20 to 8th January 21. We have collected 80 bacterial messes. We use 2 types of study, anaerobical and anaerobic culture. The bacteria are identified by Malditov. Here our result. We found 35 bacteria, among others 13 aerobic bacteria species and 14 Acinetobacter baumannii. Compared to table 2, we have isolated 48 bacteria, among others 23 anaerobic bacteria species and 7 Veinola parvula. The table 1 and 2 compared to table 3, we have isolated 132 facultative bacteria, among others 44 facultative bacteria species and 19 Staphylococcus epidermidis and Gardnerella vaginalis, which is a bacteria of the vaginal flora. This work is a writing process now. Here we describe a rare case of pneuma of a Malian woman. She had a 5 days treatment consisted of 4 drugs, 4 different drugs. Unfortunately, the patient dies a month later in her locality outside the hospital. We isolated E. coli, which resistant to 6 antibiotics commonly used in dentistry. This work is published in New Microbe and New Infection. Move on to part 2, detection of methanogens. Methanogens are detected by 3 methods: molecular approach, fluorescence in situ approach, and culture approach. In table 1, we have a detailed clinical and microbiological information of patients with facial cellulitis in Mali. 13 patients out of 79 are positive with methanogen, and the rate represents 16%. Among others, 12 Methanobacter euralis and 1 Methanosphera stadmaniae. In conclusion, this is first detection of methanogen in facial cellulitis and first detection of Methanosphera stadmaniae in the oral microbiota, because Methanosphera stadmaniae is found in the gut microbiota. This work is submitted in New Microbe and New Infection. Facial cellulitis is frequent among patients in Mali, and the profile of the associated bacteria is diverse. Study is underway to include more patients and perform a genomic analysis. Move on to perspective. This is a pilot study, and we are continuing to establish the microbiological profile of facial cellulitis by culture and genomic analysis to determine the resistance profile of the isolated bacteria and investigate the exact role of methanogen in a facial cellulitis. And finally, the transfer of methanogen culture method in SciCM. I have a new project about methanogen and a newborn. I'm laureate of a MOPA program with 1-year research visiting fellowship in IHU Marseille. I'm looking for funding of the part of collective sample and monitoring the population study. I'd like to acknowledge my team and my partner. Thank you for your attention.
Thank you. Are there any questions?
So, congratulations for your presentation.
Thank you.
I was concerned about the fungus. So, first you said that you were doing the identification for bacteria and for fungus too. So it was Malthoff for both, Malthoff, to identify fungus, fungi, because you presented there Candida tropicalis, Candida sphaeria, and Candida, I don't remember the.
In this presentation, I present only about bacteria and archaea, but this study is ongoing. We work to isolate fungi also, but we have some resistance about. We isolated Candida, one Candida tropicalis and Candida albicans.
Okay, yeah, but you didn't perform the fungal susceptibility testing for that to see if
not yet.
Not yet. Okay, thank you.
Can I have a, thank you. It was a very nice presentation, very clear, but is cellulitis very common in your region, in that region? Cellulitis that you showed,
is common in Mali.
Mali, and Staphylococcus. This is the first study showing major contribution by Staphylococcus.
But we isolated a lot of Staphylococcus epidermidis.
But is it
and others, Sos H, Klebsiella pneumoniae, also E. coli.
how can you be sure that it's the infecting organism and that it's not just from the skin?
Yes, maybe maybe skin, but we tested different antibiotics and we observed that Staphylococcus epidermidis is resistant to a lot of antibiotic. But I don't present the result because it's a pilot study. It's ongoing.
Thank you very much. I'm sorry, I'm a little bit confused regarding your sample because you have patient from Mali and you have patient from Marseille.
No patient of Marseille because I don't have a Malditov in Mali. So we have a collaboration with IHU Marseille.
This is only patient from Mali.
Only Mali.
Okay. And the number of cases, the total number of cases is 13 or 79?
79%. Yes.
Thank you very much for your nice work. And the key message is that for clinicians, while they have the cases of cellulitis and norma, etc., they shouldn't stop only looking at the classic bacteria. They also need to look at the how do you call them?
Methanogens.
Methanogens, yes. And are you planning to work on a diagnostic tool which will be very easy because it seems like it's a very demanding microorganism. So in the culture, it should be very long and complicated. So is there any plan to see how you can simplify the diagnostic and that can be reachable for clinicians, for example? Thank you.
Please to repeat.
Bon, en français, je disais que c'est un point important que vous avez trouvé de rechercher également les méthanogènes à part les bactéries classiques. Mais étant donné que les conditions des cultures sont assez compliquées et complexes, est-ce qu'il y a un plan dans le futur de pouvoir envisager un outil diagnostique plus simple pour permettre que même en périphérie, etc., que les gens puissent rapidement rechercher ces méthanogènes à part les bactéries classiques? Parce que c'est une information importante que vous apportez à la communauté au monde entier. Merci.
Thank you. It's our project to develop a more easy diagnostic in biological method in a peripheric region. Our colleague, they working on.
Last question.
As much as I understood, you collected in 2 months all these
months,
cases.
yes.
It's incredible. I have never seen this type of problem. And my question is, considering that probably some of them were already developing the clinical manifestation a long way ago, did you make a questionnaire to find out if they receive antibiotics or something like this before you took the sample?
Yes, we have elaborated a questionnaire. Certain patients take the antibiotics before the sampling. But before the sampling,
How many? 70% or 7%?
15% of person are taking antibiotics.
They took already before you made the sample.
Before, yes.
Thank you, Elizabeth.
Thank you.
Our next speaker is Rim Baya from Lebanon. Rim is currently completing a PhD at the University of Claude Bernard Lyon Premier. Our research work focuses on the identification and validation of innovative tools, including transcriptomic and immunological assays, to identify new biomarkers for tuberculosis diagnosis and treatment monitoring. You have 10 minutes.
Thank you. Good evening. I am Rim Baya. Currently, I am completing my PhD at the University of Claude Bernard Lyon 1. I started my thesis 3 years ago, which is a collaborative work between the Mérieux Foundation and the Laboratoire Microbiologie Santé Environnement at the Lebanese University. Today, I will present a multi-country evaluation of RISC-6, a 6-gene blood transcriptomic signature for tuberculosis diagnosis and treatment monitoring. No. Okay. It is important to raise our collective awareness on an infectious disease known as a silent killer, which is called tuberculosis. About a quarter of the world's population is infected with Mycobacterium tuberculosis, and an estimated 9.9 million people fell ill with TB in 2020. Until the coronavirus pandemic, tuberculosis was the leading cause of death worldwide, resulting in 1.3 million deaths in 2020. Tuberculosis is a respiratory disease caused by the bacterium Mycobacterium tuberculosis. It is transmitted by airborne droplets from an infected person who coughs next to a healthy person who can accidentally inhale droplets that contain TB bacillus. 5 to 10% of infected individuals will develop the contagious active form of TB disease, while most of them, approximately 90%, will control the infection and develop the latent TB infection, LTBI. In fact, the current TB diagnostic tests include a sputum-based culture and smear microscopy. However, these tests are associated with several limitations, including the long time of culture and the lack of sensitivity and specificity of smear microscopy. In addition, the performance of these tests are dependent on the quality and availability of sputum samples, which vary according to the population from which they are produced, such as children and HIV patients who are not able to produce sputum samples. In this context, WHO has declared that there is a crucial need for alternative non-sputum-based TB diagnostic and treatment monitoring test. Recently, a 6-whole blood gene transcriptomic signature, the RISC-6, a set of 3 genes upregulated and 3 genes downregulated in TB patients has been described as a promising transcriptomic TB biomarker. Thus, in the present study, we aim to evaluate the performance of RISC-6, a PCR-based 6 genes blood transcriptomic signature in the context of TB diagnosis and treatment monitoring. For this purpose, our study was conducted within the Gabriel network in 4 different countries, including Georgia, Madagascar, Lebanon, and Bangladesh. In total, 238 participants were recruited. Participants included 141 adults with active TB disease, 71 healthy donors, and 26 individuals with latent TB infection only recruited from Madagascar. In addition, the enrolled active TB patients were followed up during the course of treatment at 4 different time points. At baseline T0, patients who didn't start yet their TB treatment. At T1, treated patient tested 2 months after the start of the treatment. At T2, at the end of the treatment. And at T3, 2 months after treatment completion. Thereafter, from each participant, a sample of 3 milliliters of blood was collected, the RNA was manually extracted, and the gene expression of each individual transcripts was then quantified using the quantitative real-time PCR. These parameters were then applied to generate scores for RISC-6 signature. First, to investigate the performance of RISC-6 as a screening and the triage test for TB, RISC-6 was compared between active TB patients at baseline, treated TB patients, LTBI individuals, and healthy donors. In all cohorts, RISC-6 scores were significantly higher. RISC-6 scores were significantly higher in active TB patients compared to treated and healthy donors. In addition, in the Madagascar cohorts that include the LTBI individuals, we also observed a significant difference in RISC-6 scores between active TB patients and LTBI groups, but not between the LTBI and the healthy donors. Then we generated a receiver operating curve for each cohort. Remarkably, the performance of RISC-6 to discriminate between active TB patients and healthy donors was similar in the 4 different cohorts, with outstanding AUC values ranging from 90.1% in Bangladesh to 96.4% in Georgia. In addition, RISC-6 also discriminated between different stages of TB infection, the active TB from LTBI, also with a high AUC of 92.8%. These findings were then benchmarked against the target product profile set by the WHO for a non-sputum-based TB screening and a triage test that should have a minimal sensitivity of greater than 90% and a minimal specificity of greater or equal to 70%. Thus, at a sensitivity set to greater than 90%, RISC-6 demonstrated a specificity of greater than 70% in all cohorts except for Bangladesh. This shows that RISC-6 signature achieves the minimal WHO TPP for a non-sputum-based screening and the triage test, discriminating patients with active TB from both healthy donors and LTBI groups. Next, we wondered if RISC-6 signature and the mycobacterial loads were correlated. Thus, we have performed a sub-analysis on stratified smear microscopy results defined as follow: negative smears, low-grade positive smears, and high-grade positive smears. Our results showed that RISC-6 was significantly lower in negative smears than those in low-grade or high-grade positive smears. This suggests that RISC-6 signature directly correlates, This suggests that RISC-6 directly correlates with the sputum smear grade and may represent a useful tool to identify patients with high transmission risk. Our next aim was to evaluate the utility of RISC-6 as a biomarker for TB treatment monitoring. Thus, our results showed that RISC-6 signature was significantly higher in active TB patients at baseline compared to healthy donors and continued to decrease progressively until the end of treatment, reaching scores observed in healthy donors. Taken together, our results suggest that RISC-6 signature could be used as a useful tool to monitor the response to anti-TB treatment, and it may represent a potential alternative of the current test used to assess TB treatment efficacy. Notably, many tools are currently in the pipeline set by FAND and the WHO for a non-sputum-based TB test. RISC-6 are one of the most advanced in the pipeline. Unfortunately, our result has been recently published in scientific reports, which is considered as a step forward to validate the potential use of RISC-6 as a non-sputum-based TB diagnostic test. In sum, based on our results, RISC-6 can be used for multiple applications. First, as a diagnostic test, if we have a suspected TB patients from a collected blood samples, RISC-6 can discriminate between the healthy donors and active TB patients. Moreover, RISC-6 can discriminate between the different stages of TB infection, the active form of TB disease from the LTBI. And finally, RISC-6 also shows an additional applications such as treatment monitoring. It could also significantly discriminate between the untreated and the treated TB patients. Finally, our overall findings support the efforts to incorporate RISC-6 into a point-of-care test, thus reducing its complexity and cost and facilitating its implementation in the clinical laboratories located in resource-poor settings. Indeed, such a novel, simple, and inexpensive tool is highly needed to improve TB diagnosis and thus reducing TB spread and transmission, especially among population at higher risk for TB disease and who are not able to produce sputum samples, such as children and HIV patients, and who also lived in areas with a high TB burden that are usually disturbed with poverty. Currently, within the framework of the HINT study, we are evaluating for the first time a high-dimensional spectral flow cytometry analysis to characterize the specific immune response against Mycobacterium tuberculosis. And fortunately, we have identified several phenotyping and functional profiles of a series of immune cell subsets, such as CD8, CD4 T cells, B cells, and NK cells. And it seems that these immune markers are promising for treatment monitoring. And finally, I would thank all partners and investigators involved in this project, and thank you for your attention.
Thank you. Are there any questions or comment?
Yes, I have one. Thank you. Very beautiful presentation. I was wondering, in the future studies that you may do, is any thought of evaluating this signature in those with respiratory diseases? Why am I asking it? Because it is known that these transcripts may be increased during inflammation beside TB. So something that may be suggested is to perform such studies also in a control population in order to give strength to your results that are very beautiful. And probably within the community of the Gabriels, probably Florence knows better than me, there are samples stored where you can check it without enrolling new patients.
Thank you for the
Florence.
question. Yes, we collected us in the present study active TB patients who are followed up during the treatment and LTBI, and we proposed also to evaluate really risk to compare risk between the active TB patients and other respiratory disease, and this was one of the perspective that we will maybe do in the future, and maybe we will test the risk signature in the HIV. Because many of the genes are interferon gamma stimulated genes, which is increased in HIV patients. So this is one of the perspective that is maybe be used in the future.
Very nice presentation.
Thank you.
So, just asking you about the flow cytometric analysis that you did. You know that, for latent TB, we use the quantiferin test. And what markers did you look at for this?
In this study, so we used, as I mentioned, the spectral flow cytometry analysis, with which is a high potential technique, and we use 30 markers. So we use the markers, the lineage markers of the CD3 plus the T cells, CD8, CD4, and T gamma delta. And also we used other markers for such as activation markers for the T cells. And also we are currently evaluating if we find anything concerning the CD, like NK cells or B cells, to find if the innate immunity is maybe involved also in the immune response against tuberculosis.
So how much of these, the samples that you talked about for the flow cytometry, was it only done with samples from Lebanon or from?
Yes, there is samples from Lebanon and Georgia. Also, the same study, it is the HINT study that we are collected in samples, and the flow cytometry was performed on samples collected from Lebanon and Georgia.
So these all adults, I mean,
Adults, only adults.
You haven't gone to children yet?
No, as a perspective in Risk 6 is to try to find something in children. Yes.
Thank you for your presentation. Maybe I missed something, so I will apologize before beginning. What was your gold standard test to identify positive tuberculosis?
Yes, it is a culture, sputum culture, the gold standard of the diagnosis of tuberculosis. So we include only the positive culture for the study. And
how do you make the difference between latent tuberculosis and active tuberculosis?
Okay, so we tested based on also culture. So the active tuberculosis is a positive culture, and the latent was tested by quantiferon, TB Gold Plus, ELISA. Okay.
Is this for pulmonary only and not for extrapulmonary?
Yes, only pulmonary tuberculosis.
You suggested that it could be used for point of care because it's inexpensive. Do you have any idea about the cost?
So first, as a perspective, we put that we will test this in a small volume of blood, and next we will calculate the cost maybe, but actually no, we didn't have any idea about the cost, but as a point of care, it depends on the use of a little bit of tools, not for example, only all the quantitative real-time PCR. So just for example, to collect a little volume of blood.
And it would be by which technique? What would be the technique for RDT to detect? Is it a lamp technique or?
That we used?
No, but you plan to adapt to point of care.
Point of care. So currently we are evaluating to evaluate this tool into a point of care, but we are not.
You have not decided yet for which technique.
Yes,
would
so
be
it
used.
is a perspective now to perform this test on a small volume of blood and to test if there's the same accuracy of that we obtained with the 3 milliliter of blood.
So did you do, what is the minimum volume that you need?
So we collected 3 milliliter of blood and we extract the RNA from the 3 milliliter of blood and Tempus blood RNA that stabilize the RNA. There's Tempus blood RNA tubes are tubes for the stabilization of the RNA. So we collect directly in Tempus blood RNA tubes.
Okay.
Thank you.
Thank you.
Our last speaker is Tiavina Lalena Rasolofo Arisson. So Tiavina worked on the WHO Tricycle project at the Centre d'Infectiologie Charles Mérieux à Madagascar. She has worked on other projects concerning antimicrobial resistance, and she is obtaining a master in molecular biology.
Yes.
You have 10 minutes.
Thank you, Chair, for giving me the floor. Ladies and gentlemen, good afternoon. Sorry. First of all, I want to thank the Gabriel Network to letting me participate on this first Young Scientist Award. Today, I will present you the WHO project, Tricycle project, who is evaluation and monitoring of the prevalence of extended spectrum beta-lactamase producing Escherichia coli in Madagascar. We will see in this presentation the result of the HERE2 for environment and animal parts. Antimicrobial resistance is a global health problem, and specialists predicted that by 2050, we will have 10 million deaths, right, if this situation continues. The Tricycle project is part of the global antimicrobial resistance surveillance system by the WHO. And the aim of the study is to implement common, simplified, and integrated multi-sectoral surveillance system to evaluate the prevalence of a unique indicator, Escherichia coli producing ESBL. The Tricycle project have an One Health approach. We have the human part, the animal part, and the environmental part. So the CICM of Madagascar had performed the environment and the food chain part, and the human part was realized by a public laboratories network, which name is RESAMAD. The project have been about 2 years. First year from April 2018 to May 2019, and the second year from October 2019 to September 2020. Let's start with the environment part. We selected Antananarivo, the Antananarivo city, the capital of Madagascar, which we have the Ecupa River through all the whole city. We collected 2 different types of sample from Ecupa River. We have the upstream point, the downstream point. Then we collected also wastewater from the Anjiantan wastewater channel. And finally, we collected water from Angkatjatum slaughterhouse. Here are the simplified method that has implemented. First, for sampling the 4 points, then the samples were transferred to the laboratory within 12 hours. Then, depending of the contamination of samples, they were filtered or diluted. After filtration or dilution, the membrane or the diluted sample were inoculated to TBX agar to have a total number of E. coli, and TBX plus cefotaxime agar to have the E. coli ESBL. After incubation, the CFU, the colony forming unit, were directly counted in each media plate, and the number of total E. coli and E. coli ESBL was reported in an Excel file to have a concentration of CFU per 100 milliliter. After that, we isolated five colony per sample type on McConkey plus cefotaxime agar. After isolation, these colonies were submitted to indole test to confirm the E. coli species, and after they were submitted to AST test for the ESBL confirmation. All the positive isolates were stored to perform more specific tests after. And the result and data analysis were communicated to many authorities, such as Ministry of Public Health, Ministry of Veterinary, and the community who fight against the AMR in Madagascar. For the food train methods, we bought 6 chicken per week in a different market, and then the chicken were transported to the laboratory and sacrificed, and their seca were sampled. The content of each chicken seca were inoculated on McConkey plus cefotaxime agar to detect also the E. coli ESBL. After incubation, same as for environment part, 3 colonies were isolated, then tested by the indole test and the AST. After that, the whole positive isolate were stored and the results were communicated to all the authorities. As a result, we can see the concentration of E. coli ESBL on log CFU per 100 milliliter. Here we can see that the upstream of the river are less
contaminated by E. coli ESBL. Then we have the downstream of the river after the river passed the whole city. And we see an important increase. And such as the human wastewater, it is also, we have a high concentration of E. coli ESBL, and such as for the slaughterhouse water. We have here the proportion of E. coli ESBL among total E. coli for October 2019 to September 2020. So the meaning of this proportion, we see that we have a high percentage in human wastewater. We have 3.84% of the E. coli was producing ESBL. For the food chain part results, we can see here that among the 263 chicken that we had purchased, 71% of those are positive to E. coli ESBL and 29% negative. Here we can see the localization of the market of Antananarivo city that chicken were purchased in red, and in blue we have the origin of this chicken, and we can see that the origin is we have a chicken who comes from the south part of the island and some of the east part. We had three regions where had more highest value in maize, Antan Foods, and Adsirabe. So it is on the south of Antananarivo. Comparing to the year one results, we didn't see any significant difference about the E. coli ESBL concentration in environment, but in the animal, on year one, we had only 43% of E. coli ESBL, and for the year two, we had 71% E. coli ESBL, which is an important increase. To have more explanation about all the data that we had collected, we should have a comparison with the human part of the project to see the link between the three sector. And we should also compare our results to other countries. We have implemented with Madagascar the same protocol. In conclusion, we see in Madagascar that we have a few data about AMR, especially for environment and animal sector. That is why this simple and standardized 1/2 methods is really adapted to low and middle income countries who can't perform molecular characterization or sequencing. So these methods can be implemented as an AMR surveillance system in collaboration with the Ministry of Public Health. So as perspective, it will be really interesting to have molecular characterization and sequencing to to confirm all this data and to have more important and specific results. Another perspective is that the project will be continued with another big one called Triumph for improving the TRACEACOL protocol, upscaling to national monitoring. And we will add the detection of carbapenemase producing Enterobacteria. And the project will also perform the whole genome sequencing pipelines for One Health surveillance. This concludes my presentation. At the end, I would like to thank the Merieux Foundation for the funding this project and for all the support among this project. Thank you for your attention.
Thank you for your presentation. I have some question concerning the identification of your isolate. You use only the Endel test.
Yes.
Is that sufficient? Is not sufficient.
It's the whole aim of the project. It's to implement simplified methods, and for the first year, the isolates were the species of isolates were confirmed by the laboratory of emergent.
You use all other tests for the identification?
Yeah, the isolates were performed on VTEC2 to confirm the species,
Okay.
and we see that all the isolates were E. coli.
Okay. And for the detection of ESBL phenotype, you use other method for the determination of the ESBL producing strain on your plate?
Yeah, such as for the identification, VTEC2 was
E. coli may produce cephalosporinase, hyperproduction cephalosporinase, or ISAC. The strain producing cephalosporinase can grow on your plate.
Yes, of course, but well, this is the method for LMYC countries, but it is we need the molecular characterization for confirmation. But the project is really important because now we have a first idea of the statement of the IMR statement in the country, which we didn't had that before, especially for animal and environmental sector. But for more specific
Just,
results.
Simple information. If you incubate your plate at 44.5 degree Celsius, you can selectively isolate E. coli. And also for Endel test, if you incubate your tube at 44.5 degree, the sensitivity of your test is better.
I'll take a note. Yeah, but we didn't do that.
Thank you.
Yeah.
Thank you.
Thank you very much.
Are there any other questions?
Hey, I'm just curious. You isolate. I mean, you try to isolate strains from food from wastewater, right? And you use different culture media. Why is that?
Because after we use the same media, but for the environment, the TBX media is specific for counting the E. coli and the E. coli from the water. But after we we isolate five colony to do the template, the Macron K2 for the next step of the methods.
Thanks.
And we need to mention that this protocol was, the methods were developed by expert group at WHO. It's a very simplified methods to allow the implementation in LMIC. And the aim is that all countries that apply this critical protocol use the same methods to compare the data between the countries as well. That was is very simplified, but it's in order to be implemented in a lot of countries. And I have a question for you, Tiazine. You mentioned that there is a big difference in prevalence of ESBL between the 2 years, year 1 and year 2 in for chicken. Do you have any explanation for that? Do you know if the chicken comes from the same farms, or what can be the explanation of such difference?
Okay. Thank you for the question. At the yes, of course.
I was also wondering, but in the environment, you did not see the difference
No.
in year 1 and year 2.
No. Yeah. For the first year of the project, we had a veterinary doctor who purchased the chicken. So we didn't know well what she did. But for the second year, the CICM purchased the chicken, and it was in many different markets of Antananarivo, and we took all precautions to not have any intercontaminations. So these are the results.
Thank you so much.
Thank you.
So this talk conclude our session. We had a very excellent presentation from 5 young scientists with very diverse and interesting topic. And thank you also for the audience for the discussion and the excellent questions. So the jury will meet, and the result will be presented at the Young Scientific Award ceremonies. And this year should be the Young Female Scientist Award ceremony. So thank you all, and
thank you too. And whatever the result, it will be a young woman scientist who will win the award.
Thank you very much. Yeah, and I would like just to mention that the jury is composed of Delia Goletti, Philippe Van Ebs, Abdou Salam Ouedraogo, Sarah Iyango, and Nathalie Derinensi. So you will meet during the meeting, and the result will be on Wednesday.
thank you.
Thank you very much for all the speakers. And as you can see the picture of the group taken today. Nice picture. We will send to all of you at the end of the meeting. And so thank you. And we have dinner at 7:30 today. And so you have some time to relax a little bit. Thank you. Bye-bye.